Everyone. It's been a tough 2 years. There has been variants of concern, variants of interest, and variants of consequence, of which we yet don't know. Of interest and of concern, there is a lot to talk about. You and I have all been COVID warriors for the last 2 years. We don't know the difference between day and night as yet. And there are two radical, theories involved right now. So some people just rub off corona like, it's nothing, it's a hoax by the government, it's a hoax by the pharma companies, it's a hoax by this. And while we all know that some people have lost their lives, I think we've all lost somebody, someone near and dear to us. So I don't think, like everything else in medicine, there is no all or none law. It's not black or white, it's a gray. And it's a very, very big gray. And for those of you who, think that, rather I should say the non-medical world who thinks that a Google University or a WhatsApp University can help, well, newsflash, it doesn't. Because if it would, everybody would have decoded everything about this virus by now. I always tell people that, medicine is so difficult that the whole world has been trying to decode one virus for 2 years and hasn't been able to. And this is what doctors have to deal with day in and day out. Each doctor that we know of, gets into the nuances of every disease and tries to do the best for patient care. And today we are standing at a very, very interesting cusp. Many countries have seen up to 5 waves. India is in its 3rd wave. And every wave has been, designated by a particular variant. Like now we know Omicron is driving the 3rd wave. And what does it really mean for the patients, for the doctors, for the general population, for the government, for the industry? That is what we have a galaxy of stars to help you with. So I'm going to invite a very, very esteemed faculty over here, and I would welcome each one of them with, it is our pleasure and honor to have each of you on board. So can I please have Dr. Peerbhoy? Yeah. So Dr. Peerbhoy has been a consultant respiratory physician in the United Kingdom, and he has been doing it for more than 17 years now. So you can imagine that. And he was at the forefront of the management of COVID in the UK since the start of the pandemic and participated actively in recruiting for the UK recovery trials. He's a fellow of the Royal College of Physicians, London, a medical educator and a college examiner who's recently moved to India. So we're lucky to have got him. And he has experience with both the waves in 2 countries. And welcome, Dr. Shahid Peerbhoy. I would now like to welcome Dr. Deepesh Aggarwal, who is a consultant physician and HOD of critical care medicine at Saifi Hospital, Mumbai. He has been the head of critical care medicine, and along with his team of doctors and nurses, he has made the protocol for the management, formulated the treatment algorithm for patients in the ICU and wards, helped in COVID care setup in the hospital and in the jumbo COVID centers. We all know the famous and successful jumbo COVID centers of Mumbai. His main areas of interest are internal medicine, critical care, and infectious disease. He's a faculty for postgraduate and fellowship courses for doctors, fellowship for National Board, critical care, IDCCM, and DNB. He is a faculty for critical care of nursing courses as well, and an examiner for postgraduate and fellowship courses. He's an eminent speaker in national and international forums, and we are so lucky to have him with us today. And of course, my 2 very, very vibrant and intelligent colleagues, Dr. Vishal and Dr. Niranjan. Dr. Vishal Wadhwa, pleasure to have you with us. He heads the quality assurance for North, East, and our international units for Metropolis. He's an alumni from the Maulana Azad Medical College and comes with a very, very rich experience in operations and quality. He has headed diverse departments at Metropolis, including microbiology, molecular biology, quality assurance, external quality assurance scheme, and learning management system. He has been the head of the COVID project and instrumental in setup of molecular labs across geographies. And we all know the number of labs Metropolis has just, created or curated, overnight over the last 2 years. We have multiple COVID labs across the country and in various countries, and Dr. Vishal has been steering that. Dr. Niranjan Patil, who is certified in infectious disease, apart from microbiology and molecular. Welcome, Dr. Niranjan. It is really lucky that we managed to take you out from that very, very busy COVID lab that you run in the Global Reference Laboratory. He's our scientific business head and head for microbiology and molecular biology. He also heads the NACO unit and the COVID-19 lab at our reference laboratory in Mumbai. He has over 10 years of post-MD experience in microbiology in infectious diseases and is the COVID nodal officer for ICMR in state and Mumbai Municipal Corporation. He is a core committee member of the Society of Clinical Microbiologists. I welcome all of you, and without wasting any time, would invite Dr. Vishal to start with the first talk.
Yeah, thank you, Dr. Kirti. Thanks for the nice introduction. Let me share my screen. I believe my screen is visible now.
Yes, it is. Please start.
Okay, so without any further ado, let me start off with my presentation. And I'm lucky, I guess, I get the first one to be the presenter. Since this topic is so vast, as Dr. Kirti has already mentioned, doctors from all around the world are still putting their brains in how to manage these cases, be it a microbiologist, biochemist, pathologist, and the clinical people who are trying to manage COVID, but still the war is not over. So here I'm going to request you that please give me 15 to 20 minutes of your time so that I can help you understand what my fellow to speak after me. Okay. So the aim here is to, if we want to understand the PCR, the nitty-gritties of the PCR and how the variants affected the PCR, then we need to have an understanding a bit about the genetic code, basics of the PCR. What is the virus genome? What are the various variants involved in the pandemic? Their nomenclature. And finally, what is the current situation of the pandemic? Give me a minute. Okay. Go ahead. So first, the genetic code. So there will be few. I have a total of 23 slides, and I believe that I'll be able to finish just below 20 minutes. So there will be few slides which I'll be touching just to brush up your basics so that you can understand what mutations and what genetic variations are happening with this virus, so that my fellow members, when they talk about how these mutations are linked to the various symptoms and how they're going to affect the vaccines and the diagnostic bit, we'll be able to understand. So first and foremost is the genetic code. We all know this. All of this is from internet. Nothing is developed by me. So everything is there. You don't need to copy it down. So genetic code is a triplet code, as we all know, and it has, which means that three nucleotides are going to code for an amino acid. Okay. And this is a must before we understand any mutation. Apart from that, a lot of, data will be there, which will be going through in this presentation. You are seeing in newspapers as well as on the internet, which talks about mutations. So we need to understand the small abbreviation letter here for the different amino acids. For example, A for alanine, and R for arginine, and N for asparagine, D for aspartic acid. All four are starting from A, but they have a different code. So let's not get confused. So whenever you open up an internet and try to understand a mutation or what kind of mutation a variant has, you must keep on this slide in front of you so that we do not get miles away on the wrong side. So I have a question for you. You don't have to answer right now. It's just for you. So we all know that PCR was discovered by Carey Milles. Just ask yourself during the presentation or later, what exactly did Carey Milles discover? Okay. So this is the PCR cycle. And let us say this is the template DNA of interest. And the blue one is the nucleotide sequence which you want to amplify. And the green ones are the primer, which bind to the flanks of the genetic material which we want to amplify. Once the amplification starts, by the third cycle, we start getting what we want to achieve during the PCR. For those who are not aware with the PCR, which means the clinicians, the final output is very easy to understand. These curves are the PCR curves. Each curve would signify that there has been some amplification in the sample, and the output is given as a CT value. So a lot of you are observing that there are CT values. There is a lot of debate about CT values to be reported, not to be reported, and so on. So it is very easy for us to report from the PCR cycle the CT value. So this is the curve, and here we get the CT value against each sample. Okay. So that was a bit about basics of the PCR. Now let us go about the basics of the genome. So as we know, SARS-CoV is a single stranded RNA virus, and we'll understand this genome like this, going clockwise. So on the 5' end are the untranslated nucleotides. Then we have open reading frames which code for non-structural proteins. Okay, so the code is coding for two types of proteins. One are the non-structural and second one are the structural proteins. The structural proteins we all know. Spike protein is, it's all over in the newspapers. Envelope protein, the membrane protein, the nucleocapsule protein. Most of us are aware of the spike protein. Okay. Now, for those who want to understand a bit about mutations and how they affect their patients, they need to understand this table as well. So we have here is the spike protein, the structural protein, and it encodes for the binding domain, receptor binding domain. It is the area where virus binds to our cells through the ACE2 receptors. This we know. What few of us may not know, this is the target site for most of the PCR kits. Plus, this is the target sites for antibodies-based vaccines as well as drugs also, few drugs, especially the monoclonal antibodies. Now, of importance here are the non-structure proteins. The NSP means non-structure protein from 1 to 6, which are involved in packaging. Whereas we have non-structure proteins 7 to 16, they are responsible for replication through RNA transcription. This is important because RDRP, which is the RNA polymerase in the virus, is a target site for most of the antivirals. And NSP14 is the protein of great interest to us. The reason being that among the RNA viruses, coronaviruses are the rare ones who have got a proofreading enzyme, which is not there in most of the RNA viruses infecting human beings. To make it simple, which means this virus is less likely to mutate. Now, this may come as a surprise to a lot of you, but coronavirus has got less mutation ability than influenza virus because of this proofreading enzyme. Okay. And because of this proofreading enzyme, the ribavirin, which was a classical antiviral anti-nucleoside analog drug, was not able to attack this virus because of this proofreading enzyme. However, this was managed by remdesivir and its siblings because they cause a conformational change. Instead of stopping the elongation of the protein, which ribavirin would do, an exonuclease, which is the proofreading enzyme, would help destroy or the association of ribavirin. So this is an important thing to remember if we want to understand the drugs or the antibiotics used for this virus, or we want to understand the PCR, or we want to understand any mutation of importance. Okay. Now this again is of great importance to people who are core molecular microbiologists. This is the genomic structure of the virus with the nucleotide sequence length. This you can find on this side, G side. G side is a site where you can find a lot of data on coronaviruses. The importance here is that you see this is the S gene. The length of the S gene is 3821 nucleotides. The largest gene is ORF1AB with a total size of 21290. Now, why is it important? Let us say if I say so let us presume the mutation is at 28,833rd nucleotide. So if suppose let us say in your newspaper, you are reading there is a mutation there. So which means 28,800. So from 28599 to 29858 is the span of N gene. So if the mutation is at 28,833, the N gene is mutated. This is how we read it. Okay. So once we understand the genome, we are ready now to understand what is variation. So any mutation in this genome, which we have just seen, will lead to a variant. All those variants which are coming from a common ancestor form a lineage. And if on a phylogenetic tree, which we are going to discuss next, if we have the ancestor along with its descendants, it is called a clade. So throughout your internet, newspaper, the news, you'll find this interplay of words, variants, lineage, clade. So this is the meaning. So once we have a mutant which has affected the transmission, the severity of the disease, has the ability of escape. The escape could be immune, which means antibodies. It could be diagnostic escape leading to gene drop, or could be a therapeutic escape. And it is widely circulating. The WHO will call it as a variant of interest. And when it is demonstrated that this has actually impacted any of the above things, it becomes a variant of concern. So this is the slight difference, suspected and confirmed. So again, this phylogenetic tree is a live tree. Every day, the G side will receive nucleotide sequencing data from various laboratories across the world, and they'll update here. And for easy understanding, this is the, the main trunk of the tree, which is the Wuhan virus. So every mutation is based upon changes that are happening in Wuhan virus. As the mutations will keep on happening, the virus will keep on accumulating few mutations. And that reminds me, mutations keep on happening in this virus. Till December 2021, over 33 lakhs mutation have taken place in this virus. And whenever a mutation happens, it is likely that virus will die, because most of the mutations will lead either to a frame shift, deletion, non-stop code, the stop codon being encoded. Rarely it will give a survival advantage. Once we have a survival advantage, along with the above things which we have just mentioned, it becomes a variant of concern. And here we have the timelines which show that when did the variant arise. Of great interest is this Omicron. This is not a new strain. I can't enlarge this because if you go to this side, you can click and enlarge this. I can't enlarge it here because we are not live. I'm not on a live web. So if you enlarge it, you'll find this Omicron has its stem near the alpha virus. So this is very closely related to Wuhan virus directly, and it's just a sibling of alpha virus. And this itself is important. We'll be discussing it later. And by the way, each time this branching is here, which means there's a mutation of interest and the descendants are separated from each other. So this is the very basics of phylogenetic tree. So those who are interested can go to this side, G side, and you can find all the details. Now again, this is another side, CDGN. If you go to this side, you'll find what are the various mutations that variants of concern have undergone. Now this is this slide may surprise a few. Now this Omicron has got 47 mutations, and to call it a lineage, it has to have 32 mutations. And these are the various mutations that can be there in the Omicron. Now, any mutation which occurs in the 95% of the viral the nucleotide sequences received, it is of importance. Below that, they don't consider it as a mutation which can define a lineage. So a defining mutation is which is happening in the 95% of the strains. So let me read one mutation for you so that you understand how you read the mutation. So I have just pointed this red one out. A means amino acid, and S is the protein where the mutation is happening, and 6970 is the position, and the mutation is deletion, DEL. I'll just take you back so that you understand. So S protein has got number as 25,000, which means if I want to count 69 or 70th position, so I have to count from this 21290 plus 69 or 70. That is the point where the mutation has happened. So sometimes the data what adds to the confusion is sometimes the sites are referring to the total length of the genome. Sometimes they're referring to the nucleotide position, which has been responsible for encoding a gene, sometimes full sequence, sometimes only protein. So many people are not able to understand how to read a mutation. So this is how we read a mutation. I picked this one because this is very popular mutation, causing a lot of stir in the market because it is leading to S gene drop. So we'll discuss this later. This is just to show you that how mutations have accumulated with the coronavirus. So this is on this side is the total number of mutation. Alpha, beta, gamma, delta. And there's a huge jump of mutation with the Omicron. And the gene which is heavily mutating is the S gene. Now virus has to stay alive, and we are targeting the S gene, S site with our monoclonal antibodies, with our vaccines. So it is trying to mutate under pressure. So this will be the site which is going to undergo maximum mutation in future also. Till the time we formulate another regimen to attack the virus. Now there is some confusion with the nomenclature as well. Now you must be seeing some people are calling Omicron, some people are calling B.1.529, some are calling GRA, some is calling 21K. What is all this is basically there are 3 approved nomenclature societies. One is Pangolin, one is GSAIDs, one is Next Rank Late, and then one is WHO. So what is WHO doing is for making it simple for us, it has allowed all 3 societies to keep their scientific names. But for our general public, they gave it a Greek alphabet. So alpha, beta, gamma are basically Greek alphabets, and Omicron is the 15th one. Though only 5 variant of concerns have been documented till date. All the ones in between, बीच वाले सब गायब हैं. They're not important. Now these variants of concern are also situational. Alpha, you see here, alpha, which was a variant of concern on 29th December 20, is now a variant being monitored because now it is epidemiologically under control. Vaccines are effective against it. So variant of concern has become a variant being monitored. This happens over time. Now current concern is Delta and Omicron. Now this is the current data, Indian data. So on 1st January, we had 85% Delta, 15% Omicron. As on 18th January, we have 32% Delta and 68% Omicron. You can see here. So if you go to G side and there's a filter there, you put India and you find this. There are 2 tables. On the right side, you will find out, you can see, just a minute. So you can see that there are 3 columns. 1645 is the total number of Omicron confirmed with sequencing. 1203 is the number of Omicron reported in last 4 weeks. And this is the percentage in last 4 weeks. So we can see a steadily increase and, Omicron trying to surpass and overpower Delta in terms of spread. Now, since we have some amount of information on the genome, the variants, now we will be able to we are in a better position to understand what is PCR. So the entire importance of using or selecting a kit for PCR is what genes it is detecting. So now most of the PCR kits are multiplex, which means one tube assay and all primers are in that tube. And it is easy for us to perform a PCR test once we have a multiplex PCR. The genes, see, if we are going to work with a virus which is known for mutations, it is always better to have multiple primers. So it is very easy to find out. Now this TagPath kit, world famous, approved by ICMR, raised its price by 3 times. It is detecting 3 confirmatory genes, N, S, and OR. So it is sitting on the top of my list. And the list is not, in a graded fashion. Now, why they are red? Because we have only one confirmatory gene. This is Altona. One confirmatory gene, the S gene. Gene store. N1, N2 is considered one confirmatory gene. Aquila POCT, again one confirmatory gene. Abbott ID, again one confirmatory gene. Why they are red, I'll tell later. So this becomes important when you select a kit. Do not go for a kit which has got one confirmatory gene, as mutations will keep on happening and your kit may not be able to pick the concerned area of interest. Now, Are these mutations new? No, they are not new. जिसका भी हम बात कर रहे हैं, the mutations we are all talking about is this spike mutation, 69, 70 deletion. This is not there only in Omicron. It was there in Alpha also. It is there in Eta also. It is only that now we are understanding it. Not only this S gene mutation, there is N gene mutation, which was first reported in May 2020, which is way long back. And not only reported, it was published also. But I think FDA was very slow at picking it up and reporting that there is something known as N gene drop also. So this mutation here is responsible for N gene drop. So now this pandemic of Omicron is witnessing two gene drops, S gene drop and N gene drop. It is not only S gene drop. Now, this is FDA cautions released now in December, not before that. Though the mutations were happening much earlier. And look at this kit, Acula SARS-CoV. This is available in India, okay? From Misa Biotech, and they have quoted. Now, FDA is also very smart. They're not quoting amino acids. Whole world is talking in amino acids, these amino acids. FDA is smart. They're not, what they are reporting here is the mutation at 2883 position, which I was trying to explain you earlier. So if you go to the FDA site and try to find out the mutations, they have reported that there's a mutation at this site, and all the kids who are using primers who are going to recognize this site may get affected. So these 4 kits were actually, have been given caution, and one is the world famous gene expert kit. It has also received caution because it was that the primers were targeted against N2. In all these 4 cases where FDA has warned, it is because of the N gene drop. I'm still not sure why they have not released caution against S gene. In India, we are finding so much of cases of X gene, but there is no caution from FDA on this one. I've already explained that though the mutations can be many, to call it a lineage, there is a minimum number of mutations that has to be present. For example, Omicron, 47 mutations in total, there should be 32 at least. But read this line. Small percentage of Omicron may not possess this deletion, has no X gene drop. And small percentage of Delta may possess this deletion and has the X gene drop. So we are on, as Dr. Kirti said, we are dealing with a lot of grays. So there's no black and white. Let us say if my lab reports there is a COVID positive and there's an S gene drop, so we will report like that. It is a possible case of a variant. We will not classify it directly as Omicron. That is where sequencing will come into play. By mere PCR, you cannot tell what kind of variant we are dealing with. It is an educated guess. Now, when I know 70% of my cases are Omicron in Mumbai or Delhi, and if I find a S gene drop, it is likely that it is a Omicron, but still Delta is possible. So clinician, for our microbiologist, it is easy, but for a clinician, it is doubly difficult because he could be dealing a case of Delta. So what is the future? Future is relies on mutant-specific PCR, wherein the primers are detecting only the mutants of interest. So this COVID will not stop mutating. It will keep on happening. And slowly what will happen is the companies like TagPath and all those, they will prepare kits specific for a mutation. Let us say my clinician will ask me, Dr. Vishal, आप हमें को Delta coronavirus के Delta के लिए हमें PCR करो, which means we'll buy a kit for Delta PCR. Or the second option is sequencing, which is still costly. We are going to start in Metropolis and Mumbai. Let's hope. And so these are the two answers. So variants of concern which have got havoc, which can cause havoc on patients' health. I think there will be primer specific, mutant specific PCRs available soon. Now, last slide is this. So my aim was to just to bring you to a point where you can be able to understand what my fellow colleagues are going to say. It's just a small quiz for you. I'll ask the question, I'll answer. That is a good part. So these are the 3 reports, okay? I have not mentioned which lab, nothing. So first says negative, second says negative, third says positive. it is very easy to see that the third one is N of SRDRP. So this lab is using a kit which has got primers against 4 confirmatory genes. It has put some oblique, which means it is using 3, not 4. That is okay. There's no kit with 4. So what is happening now is this is a good kit. Now these 2 kits, if I see a report like this, I'll pay a little caution here, especially not to this S gene. I'll be more worried about N gene also, because this is not printed anywhere in our newspaper. There's an N gene drop also. A kit using N1, N2 as target genes is also likely to fail in detection of the SARS-CoV. So I think with this, we are now more acquainted with terms of mutation, how different variants have come up, and how we should be able to see them in light of the PCR results. With this, I like to go back to Dr. Kirti, and maybe we can invite the next person. So thanks, everyone.
Thank you so much, Dr. Vishal. That was an amazing walkthrough, and I'm sure everybody is all primed for the clinical side. As our honorable chairman always says, we are the doctor's doctor. So, we can say this is there, this is what we are finding in the lab, but ultimately it's up to the clinician to put everything together. And that is what they are so good at doing. And I would take this moment actually to thank all the clinicians across the country. India is such a, intensely populated country, which itself is bad news for a, pandemic. And still the way our junior doctors, mid-level doctors, senior doctors, the way everybody has managed all the waves. And, we've just excelled in numbers, not in mortality rates. And that is something which I think all of us can take a bow. And we can thank every clinician who has, battled it right in the center of it all and has given us excellent rates as far as, survival and even the complications are concerned. So with that, I would invite somebody, Dr. Deepesh Aggarwal, who has been at the center of it all. As I said, he heads the critical care at Saifi Hospital and has been a part of jumbo centers. Now, India is a resource-poor country. And how do you divert the resources? When do you do a test? When do you not do it? When do you do biomarkers? What treatment do you start with? And all that depends upon, you can have any virus, but what is the symptom or sign in your body which calls for action? What is really actionable? And that is where our efforts should go. Otherwise, we'll be just running helter-skelter and not really, helping. So can I invite Dr. Deepesh Aggarwal to please take us through the clinical, profiles of the variants of concern.
Yes, thank you very much. Hi, if the host could allow me to share my video. Hi, I'm Dr. Aggarwal. I will be speaking regarding clinical profile of variants of concern. Some of the slides may overlap from the previous speakers, and I'll try to make it crisp. So we all know COVID is a global pandemic since 2019 end, and we've had more than 262 million cases and about 50 lakh people have died. This is actually tip of the iceberg because of reduced testing, and the correct numbers will only be reflected subsequently, maybe if a serology study is also done. As the previous speaker said, all viruses evolve over time. The more the virus circulates, the more it will evolve. It's survival of the fittest. Most changes in these viruses have little or no impact upon the virus's properties or behavior. The viral replication is an imperfect mechanism. It does not have those corrective mechanisms like advanced life forms like humans, etc. However, some changes may lead to emergence of variants that may affect its transmissibility, disease severity, and its efficacy to vaccines, therapeutics, and diagnostic tools. So there are several variants identified, of which one of them is variants of interest and variants of concern. The three key properties are its transmissibility, its virulence, and the ability to evade immune response. So a variant of interest is the one which has genetic changes and affects one or all of these three characteristics, and it should also cause community transmission. Then what is the variant of concern? A variant of concern is the one who meets the definition of variant of interest, but of the three characteristics, it should be having increased transmissibility, increase in virulence or severity of disease, or it should be less effective by public health measures in diagnostics, vaccine, or treatment response. Just a small overview. The incubation period of illness can be as little as 2 days and up to 14 days. And the virus shedding in asymptomatic cases is significantly longer than the symptomatic cohorts. But we do not know how long that person may shed a virus which is infective or not. The longest infective virus has been isolated from a patient with hematological malignancy. It was for 104 days. That patient was then treated with monoclonal antibodies to eliminate the virus shedding and active replicative phase. So on the basis of clinical severity, a case can be defined as asymptomatic, where the test is positive but has no symptoms. A mild case, where the patient may have mild symptoms such as fever, cough, sore throat, malaise, headache, like any viral illness, but no shortness of breath, dyspnea, or abnormal chest imaging. A moderate illness is the one whose saturation is okay, but there may be signs of lower respiratory disease and on clinical and imaging. Severe illness is when there is hypoxia, that means the saturation is less than 94%, and when you do a blood gas, the PaO2 to FiO2 ratio is less than 300, or the patient is breathing fast, that is tachypnea, with an RR of more than 30, or more than 50% of lung infiltrates. A critical patient is the one who has overt respiratory failure in multi-organ dysfunction or with shock. So, as we said, incubation period may be as short as 2 days to 14 days. Most cases are between 4 to 5 days after exposure, and 95% will have symptoms within 11 days. 33%, that is 1/3, will never develop any symptoms. And many of the asymptomatic patients may have CT findings if they do a CT scan. A pre-symptomatic is an individual who is asymptomatic at the time of diagnosis. For example, you go on an airplane and you're exposed to a COVID positive case, and then you test it. You may yourself be positive, but you may not be having symptoms at the time of testing, and subsequently you may develop symptoms. Then a mild to moderate cases are about 81% of the cases. Severe cases are 14%, and critical cases are 5%. The case mortality ratio overall is 2.3%. It is more with elderly age groups and those with more comorbidities, and lesser in younger age group and those who are fitter. So here the issue is not just years in terms of chronological years, it is actually also the biological years. So there is a difference between chronological age and biological age. You may be a 70-year-old extremely fit person, or you may be a 30-year-old unfit person, and the disease will affect you differently. A 70-year-old may just escape through with no symptoms, and a 30-year-old with lots of comorbidities and poor biological age may have a worse clinical outcome. Some patients who have mild symptom initially this is the pre-symptomatic phase, can subsequently develop disease with rapid clinical deterioration. It can occur 1 week after symptom onset. The median time to onset of dyspnea is 5 to 8 days. Time to ARDS is 8 to 12 days. And hospital symptom onset, admission to symptom onset is about 7 days. The ICU admission is 9 to 12 days. So here we would like to differentiate the virological phase, where the patient is symptomatic and having viral illness such as fever, cough, etc. And then there's the immunological phase, where the immune response kicks in and you get a cytokine release syndrome and you get lung damage. One thing I'd like to point out here is with the Alpha variant and the Omicron variant, the symptoms onset of dyspnea is longer. Delta variant had shorter onset of dyspnea. We've seen as short as 2 to 3 days after the disease onset. And that was the problem. That means you went to a doctor who said, okay, you have this disease, come after 3 days. By that 3 days, the patient is so dyspneic and landing up in the hospital. That's what we saw with the Delta variant. Among all hospitalized patients, around 30% of the patients were admitted to the ICU, and the mortality amongst patients with ICU was more than 50%. So the ICU patients were actually the severe cases. The criteria for most institutes was very set internationally, but in India we have cases, eminence-based admission protocols where, with abundant caution, certain people would get admitted in a hospital, which actually did not require hospitalization. So now, which are the comorbidities that put you at risk? Any and every disease can put you at risk. This is arranged alphabetically and in no specific order: cancer, stroke, heart problems, chronic lung illnesses. So basically, the degree of severity of each disease is important. So you may have mild heart disease and you may have an okay outcome, but a patient with severe heart disease, stage 4 or class D of heart failure or lung disease, will have a worse outcome. The worst hit from the lungs were the interstitial lung disease patients. You may have a kidney disease where the mortality would be higher. The worst outcomes of patients were those with hematological malignancies, because in such cases, the blood could not eliminate the infected cases. Now, what are the symptoms? The symptoms appear 2 to 14 days after exposure. It starts with fever, headache, sore throat. You can have a coryza-like symptoms with runny nose, loss of taste or smell. The myalgia symptoms, which is fatigue, body ache, shortness of breath in the lungs, and nausea and vomiting. So half the patients had cough and fever. Some of them had 1/3 and myalgia and headache. 1/3 of them developed some amount of breathlessness. About 20% developed GI symptoms. About 10% developed loss of smell. It was more common in women than men. And coryza-like symptoms. That symptom is more common with the current Omicron strain as compared to the other strains. Extrapulmonary manifestations were skin manifestations, cardiac manifestations, endocrine manifestation, where certain patients had worsening of their sugar control and diabetic ketoacidosis, GI symptoms, kidney symptoms such as hematuria, proteinuria, and kidney injury, elevated liver enzymes, venous thromboembolic disorders. I'll discuss about this in detail. Various neurological, post-viral neurological syndromes such as headache, dizziness, a fugue-like state where the patient felt fuzzy and had poor memory. GBS, Guillain-Barré syndrome. There was also cases of transverse myelitis, which have been recently been identified more with Delta and other variants. Dermatological manifestations. The patient may have all forms of dermatological manifestations such as maculopapular rash, discoid rash, more commonly in children and young adults. You may have hives, vesicular eruptions, papilloscomas, erythema multiforme, dengue-like, and the more serious illness which is coming to the fore because of poor immunization penetration in the young children, which is called MIS-C syndrome, which is multisystem inflammatory syndrome in children, which is an erythematous polymorphic rash, and sometimes with induration of hands, feet, oral and conjunctival mucosa. This is associated with systemic and lab findings and imaging of atypical and severe Kawasaki's disease. So this is a MIS syndrome. This is the tongue manifestation. These are the vasculitic infarcts. This is the peripheral signs of COVID and various other skin manifestations. Many patients used to say that they've had severe hair loss. It's called telogen effluvium after the patient recovers from the illness. There is also, because of the inflammatory condition and cytokine release syndrome, the increased production of TNF alpha also led to significant weight loss towards the end of the disease condition, and also during the recovery phase, which is actually good for certain patients who lost up to 10 to 15% of the body weight, which then increased after the recovery. Lung manifestations is one of the most dreaded, in which you get ARDS and pneumonia, hemodynamic derangement and hypoxemia. Cardiac manifestations, all of them can occur. You can get arrhythmias, conduction disorders, myocardial injury, cardiogenic shock, myocarditis and cardiomyopathy. Stress cardiomyopathy is an important thing. Microvascular dysfunction and thrombosis is a hypercoagulability, and cytokine release syndrome. Neurological complications, stroke, etc. can also be seen. The important issue here about cardiovascular syndrome is patients who have recovered from cardiac function may still be at the risk of cardiomyopathy and cardiac arrhythmias later in life, which we may come to know after monitoring for the next few years. And those with neurological respiratory virus infections are associated with neurological and psychiatric sequelae, such as Parkinsonism, which was first identified in patients in the Spanish flu, which can also occur here, dementia, depression, and PTSD because of the stresses of COVID and anxiety. A lot of mental issues because of isolation can also be seen. Cognitive decline can also be monitored and should be monitored in patients in recovery. What about the lab testing? Comprehensive labs are required in those patients who are admitted. Mild or asymptomatic patients may actually not be tested, except for the cases in Delta variants, where the period of onset of illness to severity of disease was very quick and rapid. And sometimes you could preempt a worsening by doing certain inflammatory markers. So we do a CBC and a coagulation full profile studies. Comprehensive metabolic panel is a sequential multi-channel analyzer. Cardiac enzymes with troponin and BMP, and inflammatory markers, CRP and ferritin. IL-6 was brought to the fore by the Japanese and the Americans. One practical problem that I faced was there's a lot of inter-lab variability and same lab variability in interleukin-6. A patient with almost normal was very high interleukin-6, and it produced undue anxiety in those patients. And then there were certain other patients who were extremely sick on ventilator, and the IL-6 was not that high. Probably there is ex vivo magnification of IL-6 and also the time of duration of processing. My pathology team and the Metropolis team would shed light on this IL-6 to the point I've stopped doing IL-6 now for most of my patients. There is also called lymphopenia. There is lymphopenia in patients. With these patients, the patients that were more severely ill had significant lymphopenia, suggestive of poor cell-mediated immunity. There was leukocytosis. We've seen counts of 30,000, 40,000 also. The problem with such high counts is it makes the clinician tend towards prescribing unnecessary antibiotics. We had cases in our ICU where the counts were 30, 40,000, and we were told, why aren't you starting antibiotics? We, in our patients, did not start any antibiotics for this because you can get significant bone marrow response in form of WBCO being so high. Elevated liver enzymes and LDH was there. Inflammatory markers were high, associated with severity of illness. We monitored CRP and sometimes ferritin. We stopped monitoring interleukin-6. D-dimer and lymphopenia was also associated with mortality. One important thing I would like to point out regarding D-dimer was, this was our observation, that patients who were very sick had high D-dimer, but when they were recovering, the D-dimer shot up significantly. So if you just look at D-dimer in isolation, you may be misled. The probable explanation is when the body recovers, when the clot is formed, there is fibrin, and in the degradation products also can be a sign of clearance of the problem rather than worsening of the problem. So if you see a clinical improvement and a sudden rise in D-dimer, if you do a sterile D-dimer, it may actually be a good sign. Procalcitonin was typically normal, except in cases who got secondary infection. Procalcitonin also has false positive results, especially if you have a cardiac injury and acute kidney injury. In addition, testing for other pathogens is also important because in our zeal to look for COVID, we forgot other diseases. A help here would be to use respiratory panels if you have, because towards the end of the Delta pandemic, we had a lot of influenza cases and other respiratory syncytial virus cases between September to December, where we did a biofire panel and we found out non-COVID viruses, including non-COVID coronaviruses, OC43 and other similar coronaviruses, respiratory syncytial viruses, and flu viruses. A baseline ECG is always important to help you look for a myocardial injury. Radiological testing, X-ray will look for airspace consolidation, but it is a very inferior test as compared to a CT scan, which would demonstrate bilateral GGOs, then some spaces of dense consolidation. There may be pleural thickening, interlobular thickening, and air bronchogram. Patients who presented within 2 days of diagnosis had normal CT. Such patients, when we did a serial CT, also had lung abnormalities. Sometimes a CT abnormality detected COVID earlier than actual RT-PCRs. Given the clinical variability in chest imaging, CT scan alone should not be recommended for diagnostics, and an echo should also be done in all serious patients. You can do a venous thromboembolic study by doing a CTPA in specifically indicated patients. So this is an example of subpleural peripheral infiltrates, and this is the CT of the same patient which showed the disease. This is another CT scan which shows bilateral multifocal round patchy GGOs. Apart from that, there is superimposed interlobular septal thickening and crazy paving appearance. This is a histopathological examination of the patients which had lung injury with platelet and fibrin thrombi indicative of coagulopathy in small vessels of the disease. The pulmonary interstitial damage and functional decline caused by SARS-CoV-2 recovered most of the time. We've had cases whose severity was 25 on 25 and 20 on 25. And those patients over the next 6 to 18 months have had near normal lungs with some minimal residual fibrosis. We've had multiple such series. Also, those patients who were given extensive steroid therapy had femoral head necrosis, but it was not progressive and was also reversible in most cases. Now, an important topic that I would like to discuss is the coagulopathy in COVID cases. There are various lab predictors of coagulopathy, such as D-dimer, fibrinogen, and CRP levels. Higher the D-dimer and CRP associated with greater risk of thrombosis, and inflammatory markers such as CRP, ESR, and ferritin also. So this is a very interesting slide in which depicts about COVID-19 and coagulopathy. Everybody tests for PT-PTT and also looks for thrombosis and says, okay, this is vaccine associated or this is disease associated. But there's a huge spectrum of problems that can predispose you to thrombosis and thromboinflammation. So there's something which is called a two-hit mechanism or multi-hit mechanism. You may have an underlying propensity of certain diseases, and COVID just potentiates that problem and leads to thrombosis. So on one spectrum, there is more thrombosis, and the other spectrum, there is inflammation, and there is something which is called a combination of thromboinflammation. You may have excessive thrombosis or excessive inflammation, and which produces a perfect storm to produce thromboinflammation. So TTP, HUS, antiphospholipid syndrome, DVT, thrombophlebitis, vasculitis, sepsis, irradiation injury, sickle cell disease, major trauma, transplant rejection, preeclampsia, and severe burns are the causes of thrombosis. Certain inflammatory diseases such as rheumatoid arthritis, SLE, hypertension, and atherosclerosis can then also lead to thrombosis along with inflammation. Endothelitis is the postulated to be the central feature of pathophysiology. SARS-CoV-2 binds to the host cells via the ACE receptors, as was discussed by my previous speaker. There is high density of ACE receptors on the endothelial cells. And these endothelitis and virus inclusion bodies in endothelial cells have been reported amongst autopsy samples of such patients who had severe disease. ACE receptor density also and its binding by the various variants of concern leads to the disease severity and the symptoms depending on the location of binding. I'll just elaborate this in the subsequent slides. So the Firkov triad of COVID-19 is there is vascular endothelitis, there is endothelial dysfunction and altered blood flow, and finally there is activation of coagulation cascade with platelet activation, viral DNA, DNA-NEATs, von Willebrand factor, factor 11, and final thrombolytic protein. When you get all three combined, you may actually produce thrombosis, which can happen anywhere in the body. So the autopsy evidence suggested that there is, apart from alveolar damage, there is organizing microthrombus, which can worsen the clinical picture. Now about COVID reinfection. Reinfection is defined as clinical recurrence of symptoms compatible with COVID-19, a positive PCR test, but more than 90 days after the onset of primary infection, and supported by a close contact or exposure to a COVID positive case with no evidence of other cause of infection. Such patients recovered from the primary infection and then after 90 days had a reinfection. Serology may not help you diagnose the reinfection, because it can be positive or negative after the first infection. Reinfection usually occurs when you're infected by a variant different from your previous infection. Now, what is the relapse? Relapse is defined as the recurrence of symptoms by positive PCR within 90 days and is supported by absence of an epidemiological exposure and other cause of illness. This is the same strain is usually causing the relapse, and an inflammatory syndrome as a result of inappropriate immune response has been suggested to be an alternative explanation. Most likely you're relapsing because your immunity is poor and the inadequate clearance of the bug was there. So I had a personal case where the patient had severe combined immunodeficiency. That patient, in a span of 3 to 6 months, had multiple relapses from the disease. He would be given, he got 2 cycles of remdesivir 5 days each. He would improve, go home, and again come back. This patient used to get IVIG on a regular basis. He was then treated with antibody cocktail. He was last year, and after which he did not get a relapse. So the life of antibody cocktail is from 4 weeks to 8 weeks, and it produced clearance of the virus from his body. Now, what is repositivity? Positive RT-PCR following a negative test in an asymptomatic patient from the first episode. It does not represent a replicative virus and does not require isolation. Now, this is the virus-induced susceptibility to secondary bacterial infection. This is just a proposed model. So, during an inflammatory phase, you have increase in IL-1, IL-6, TNF, and 5 interferons with loss of ciliary function and epithelial death. Then this produces the dysbiosis in the respiratory tract and increased propensity to secondary bacterial infection. Sometimes you may have gut dysbiosis and dissemination of gut bacteria, which is then filtered into the lungs, and you can get secondary bacterial pneumonia. There is no increased risk of secondary bacterial pneumonia in COVID as compared to the other respiratory viruses. It depends upon the host clinical response. And as a rule, I never prescribed those higher antibiotics for such patients. When do you get prolonged detection of SARS-CoV-2? Some patients who have recovered from upper respiratory tract infection after the 19 days of illnesses, they may have detection. Some patients present with severe illness might produce replicant virus beyond 10 days. As I said, those with hematological malignancies are the ones who will have prolonged virus shedding beyond 20 days. The longest found was 104 days. This patient had acute leukemia and was treated with monoclonal antibodies. Another interesting syndrome is the long COVID, which has been coined as PASC, which is post-acute sequelae of COVID infection. Roughly 10 patients of the coronavirus patients may experience long COVID syndrome, such as chronic fatigue syndrome, body aches, joint ache, breathlessness, cough. These coughs can last for months together. Some chest pain, pleuritic pain, loss of taste or smell, headaches, brain fog, such as memory and concentration problems, sleep problems, behavioral problems, rash, and telogen effluvium. Organs affected may also include heart, such as cardiomyopathy and congestive heart failure, chronic lung scarring and fibrosis, ischemic stroke, seizure, GBS, transverse myelitis, which is a recent finding, increased risk of developing Parkinson's and Alzheimer's disease. One common theory amongst patients with long COVID symptoms is that the virus possibly remains hidden in the body and is not cleared completely. And also, sometimes the immune system overreacts. That is a dysregulated immune system to the infection that has been cleared. Now, the variants of concern, this is the slide shared by my colleague previously, alpha, beta, gamma, delta, and Omicron. These are the various methods. So the alpha has increased, all of them have increased transmissibility, including the Omicron. The impact of immunity was similar. The delta having one of the most chances of immune escape and severity of disease. And Omicron has a relatively milder disease as compared to delta. Omicron is highly infectious and so was delta. So the alpha variant had 50% increased transmission with increased severity and hospitalization. Beta also had a similar thing. Regarding the response to monoclonal antibodies and convalescent plasma, my subsequent speaker will discuss regarding the same. An important part here regarding delta was it increased transmissibility rapidly progressive disease with increased severity, and a reduction of monoclonal antibody response. And hence, it was also a variant of concern and produced one of the highest mortalities that we saw. And it coincided with our second wave in India and third wave in other countries. Based on the preliminary data, Omicron is more infectious, but it is less severe disease. So the Delta variant is twice as contagious as the earlier variants, very severe illness, great risk of transmission amongst those who are unvaccinated. People who are fully vaccinated also got breakthrough infections, but their severity was lesser. Also, the spike protein vaccines were less effective against Delta variant and subsequent variants in protection against severe COVID disease. Omicron was the variant of concern, huge amount of mutations, and especially the spike proteins which were mutated, which is a target for immune response and vaccines and also for monoclonal antibodies. It is more transmissible as it binds to the cells specifically. So Omicron, more transmission, increased risk of reinfection because it escapes the immune response. Detection is similar with an S gene drop, and the management, although the steroids and IL-6 receptors will work because they don't target the spike protein, but the others may be ineffective, and more data is emerging as the pandemic spreads. In South Africa, it produced a milder disease with 1/5 the mortality of Delta variant and other variants. ICU admissions was also 1/5, and length of stay was half the others, and the age was younger. Fully vaccinated also had breakthrough infections. These fully vaccinated were actually the spike protein vaccination, which is Pfizer, Moderna, AstraZeneca, Chadox, the one which is available in India, Covishield. Milder illness, lower levels of virions in the lung tissue because of the receptor binding, milder features. It had higher rates of symptoms in the upper airway, such as the rhinitis and coryza-like symptoms. Although the disease severity is less because of the absolute high number of cases, the hospitalization may be higher for the absolute number and burden to the healthcare system. Spike proteins are less effective and decrease efficacy to the antibody treatments. Please follow COVID compliant behavior, such as hand washing, social distancing, coughing, covering your mouth, wearing mask, ventilation, and appropriate therapy. That brings to the end of my talk. Thank you very much. I hand over to the moderators now.
Thank you so much, Dr. Aggarwal. That was indeed very, very insightful. And all the best to you for the journey continues, I guess. And if it is not one, another challenge in the ICU. So all the best. Dr. Shahid Peerbhoy, would you like to come in now, with your experience of UK and India? And as we all know, every wave came first in UK and then in India. And there was even a variance of the variants noted within the waves also. So I think it will be very interesting to, if you could just take us through your journey and then focus on the management, which already the stage has been set so well by Dr. Aggarwal.
Right. Hello, thank you, Kirti, for the introduction, and that was an excellent presentation by my earlier speakers. So we are almost 2 years into the global pandemic, and from the point of view as a physician, from the scientific side of things, as we can see, it's been a very fascinating journey. It's no doubt taught us a lot, but it's also been a very emotional and personal journey for many of us, with several sacrifices that we and our families have made, and the suffering that we have seen. The virus itself and disease presentation and treatment have evolved and are continuing to evolve. It takes me back to the start of the pandemic. So I was in the UK, and my director called me and he said that your family lives in India, I would advise you to go now if you want to be with them. And I couldn't understand why he was saying that at the beginning. But with the army background, and I said, well, this is time for a fight. I'm not going anywhere. We're going to fight through this together. And then for almost 9 months, I was stuck in the UK, far away from my family, and isolating with just my studio flat and hospital visits. So, and it just hit like a tank. There was virtually no available data at that time, and very quickly the hospital was flooded. Several of my colleague consultants had got affected, and at that time, apart from giving supportive treatment, there was virtually nothing. So I think we've come quite a long way since then to the era of the Omicron, which Dr. Aggarwal has put so well. Now, what is new in the third wave is that we know much more, though the field is still rapidly evolving and there's still a lot to be known. Another thing that is different now is that vaccination is more prevalent. About 61% of Indians, as per recent press releases, have been fully vaccinated, with 89% having received at least the first dose. Another thing that is different is that there are variants of concern in circulation. Presently, the Delta seems to be still within the community, but in many countries, the Omicron appears to be replacing it as the primary strain. Obviously, public and political attitudes have also changed quite significantly, though there has always been a conflict of opinion among people right from the start. Now, I'm sharing a screenshot of one of my bosses from the Armed Forces Medical College, who's still a very senior consultant. This is a screenshot of his Facebook post. So it's very interesting. He's saying most of my patients are having COVID symptoms and are refusing to get tested with an RT-PCR as they're sure it'll be positive. And this is true community spread, and good part is all are recovering fast. And even in hospital, there were fewer patients where he works, and that we're progressing for herd immunity. But the reason I'm sharing this is it just highlights the change in the public attitude after having borne the brunt of so many lockdowns and restrictions over the last few months. From the point of view of management, as a clinician on the ground, predominantly my experience has been in the UK, where I have been working on the acute medical and the respiratory wards, where we have been delivering care up to the level of CPAP and non-invasive ventilation, after which the patients move on to our intensive care colleagues, where they get invasive mechanical ventilation. And some of our patients have been referred for ECMO as well to our center in Cambridge. So how I look at a patient with COVID when they present in front of me is identify what is the disease severity, what are the comorbidities, what is the clinical frailty score. So that can really quite predict. It's quite obvious right from the start that the older you were, but as Dr. Aggarwal has pointed, it's not just the chronological age, but your biological age as to how frail you were. And that was definitely deciding what the prognosis would be. Obviously, resource availability, we have been stretched like probably never before. I've never had to ration healthcare resources like we have, and it can take quite a big emotional toll. But there's no doubt that the management of our COVID patients, wherever we are in the country or indeed in the world, will depend a lot on the resources that you have available. And last but not the least, it is local protocols that are in vogue. And in many ways, I envy my colleagues in India, where they tend to have a lot more independence in deciding and governing individual patient management, which to a large extent we have as well. But in the UK, we are more restricted by our local protocols and guidelines. The management broadly, initial evaluation, general management, COVID-19 specific treatment, the management of complications, that is mainly hypoxemia, ARDS, thromboembolic disease, multi-system involvement, and as Dr. Aggarwal has touched, the post-COVID syndrome, or we call it the long COVID syndrome. And again, there are special situations in management, which I will not be touching upon in detail. That is management in pregnancy and children. They will be governed by a different set of guidelines. So in the initial evaluation, the steps are stratify the disease severity right at the beginning, at the point of presentation. The second is stratify the risk of severe disease and enlist the comorbidities of the patient. You need to make a decision. Are you going to treat the patient as an outpatient, or are you going to admit the patient? And in the hospital, there has to be an appropriate level of monitoring and treatment. And depending on where you work, you have to ensure that the patient is on the appropriate ward under the right set of specialists. This is very well captured, like this mild disease, moderate disease, and severe disease, depending on the symptoms. That's mainly shortness of breath and the level of hypoxia. So anyone whose oxygen saturation is less than 90% is straight away severe and needs to be under very close monitoring right from the start. And this is the list of comorbidities. It's quite standard. Dr. Aggarwal has touched upon as well. It virtually includes almost any chronic disease, including subtle things like obesity, which a lot of us tend to have, but we might sort of pass that over as a comorbidity. But we have seen all along, really, that the bigger you were, the more likely you were to have an adverse outcome. So a BMI greater than 30 or being even overweight is considered as a risk factor. Obviously, smoking, hypertension, and the whole lot. There are some lab parameters which point to more severe disease. That's why we do the D-dimer panel, CRP, LDH, troponin, ferritin, creatine kinase, and look at the absolute lymphocyte count as well. So this is mandatory as a baseline for anyone who's admitted to the hospital. And then you have to subsequently do it at regular intervals during the inpatient stay. General management, I'll just touch upon briefly. It is crucial with or without COVID-specific treatment and is not to be underestimated, because as we all know, there's no magic bullet which is going to cure COVID. And really your outcome to a large extent depends on how well you're managing the patient as a whole, even without very effective COVID-specific treatment. So careful attention to supplemental oxygen, ventilatory support, close management of the patient's comorbidities, making sure that they're receiving adequate and appropriate thromboprophylaxis, and you're looking out closely for the development of venous or arterial thromboembolic disease, looking out for secondary infections, that is bacterial, TB, fungal infections, as well as we know so many cases of mucormycosis. And more recently in the NICE guidelines in the UK as well, they have included a section on COVID-associated pulmonary aspergillosis. And last but not the least, providing them with organ support, which is within the domain of our intensive care colleagues. Oxygen, as this is just a rough slide which shows that it starts from nasal cannulae, progressing on the wards at least all the way up to non-invasive ventilation, and then on ICU they would get invasive ventilation or ECMO. And just in the middle, you see the nasal high flow oxygen. So I remember even before our first patient of COVID had hit our hospital, they were already discussing the contingency plan for oxygen supply, because it was thought that the nasal high flow oxygen, because you can need oxygen flow rates up to 70 liters per minute, and that would drastically reduce the amount of oxygen available. And therefore, we tended to, once they were on 15 liters or non-rebreathe mask and not maintaining saturations, we put them onto CPAP rather than high flow nasal oxygen. So that's been our experience. Also, keep in mind that both high flow nasal oxygen and CPAP are aerosol generating procedures, and therefore the PPE, particularly if it is rationed, needs to be changed appropriately. Thromboprophylaxis, another very key element in COVID patients. As has been touched upon, COVID is a pro-inflammatory hypercoagulable state, but it's important to recognize that the patients are both at risk of clots as well as bleeding, and very often these can be microclots and microhemorrhages, and therefore, at least as much as is visible, you have to do a daily risk assessment for risk of clots versus risk of bleeding. In early case series, they thought that the VTE prevalence was as high as up to 43% despite prophylaxis in ICUs. But subsequent studies showed that the incidence prevalence is about 5 to 10% in ICU patients and a little lesser on the medical wards, but this is still a large number. Venous thrombi being more common than arterial thrombi, and all patients should be offered standard thromboprophylaxis unless it is contraindicated. Another important point that is to be made, and Dr. Aggarwal has so beautifully highlighted regarding the D-dimer, is that before COVID, the D-dimer used to be a very important sort of parameter which we used to risk stratify those who were having venous thromboembolic disease, but not anymore in COVID, because it can be increased as a marker of severe disease and also during recovery. So the decisions regarding anticoagulation have to be made on clinical grounds rather than the D-dimer alone. Now, if the patient is already on therapeutic anticoagulation, such as say warfarin or rivaroxaban or something for AF or previous thromboembolic disease, you should continue the therapeutic dose. Consider switching to a low molecular weight heparin because it's easier to stop it if there are any bleeding complications. And low molecular weight heparin is preferred, but if there's severe renal impairment, you would prefer unfractionated heparin. And if the patient has got heparin-induced thrombocytopenia, you can use alternate drugs like fondaparinol. Using aspirin, there's no clear benefit in VTE prevention. This has been an evolving field really, and I think we've not yet sort of heard the last on this, but there have been sort of studies to look at intermediate and therapeutic dosing of low molecular weight heparin, particularly with our intensive care colleagues, compared to standard prophylaxis in selected patients. But studies so far have not shown any consistent benefit for using a higher dose of low molecular weight heparin. And therefore, the guidance stands that we use prophylaxis. And if we suspect they've got a DVT or a PE, then you would increase it to therapeutic doses. And if there's a new DVT or pulmonary embolism during admission, you should continue treatment anticoagulation for at least 3 months, because this would class as a provoked thromboembolic episode rather than an unprovoked one, where you would need to use the treatment for longer. Now, just a whistle-stop tour of what we have in terms of COVID-19 specific therapy. Now, if I was doing this presentation several months ago, the list would probably have been longer because there were so many potential treatments that were forwarded right from the beginning. But we have now sort of narrowed it down to about 5 main groups of treatment. So number 1 is dexamethasone and steroids. Second is the interleukin-6 pathway inhibitors, that is tocilizumab and sarilumab. I've got some experience with as well. In the use of JAK inhibitors, that is baricitinib, remdesivir. It's been quite a lot in the news during the pandemic in India early last year. And the use of anti-SARS-CoV-2 monoclonal antibodies. So these are the 5 big, broad groups of COVID-19 specific treatment. Now, this table, just in a nutshell, depending on the level of oxygen or ventilatory support that they require, if the patient is on low flow oxygen, you would offer them dexamethasone or any steroid, and remdesivir, that is if their disease is severe enough but requiring low flow oxygen. And if the patient is immunocompromised and they're earlier on in their admission, particularly if they've been not vaccinated, or if you expect that they would have had a poor antibody response, or indeed if you've got your anti-spike protein antibody levels found to be low, then you can see whether a monoclonal antibody therapy can be used. If they're having high flow oxygen, so even if the patient initially came in on low flow and is now moving to high flow oxygen, you'd still give them dexamethasone with or without remdesivir, but you'd also consider adding in tocilizumab or baricitinib. And if the patient is on mechanical ventilation or ECMO, then it's dexamethasone. And if they're early on in the ICU admission, then add in tocilizumab. Obviously, these are just broad guidelines that you'd have to tailor it specifically to your patient. So dexamethasone steroids, it's recommended for severely ill COVID-19 patients who are on supplemental oxygen. The dose that's been studied in the recovery trial was 6 milligrams daily for 10 days or till discharge, whatever comes sooner. Alternatives would be prednisolone 40 milligrams, hydrocortisone 150 or methylprednisolone 32. So any of these can be used. And more importantly, there's a recommendation against the use of steroids for prevention or treatment of mild to moderate disease. That is, if the patient is not on supplemental oxygen, the recommendation now is that you do not use steroids. The adverse effects of steroids most commonly are hyperglycemia, and very commonly we need to start patients temporarily on subcutaneous insulin till such time as they're on steroids. Also, there's an increased risk of infections, which may be bacterial, fungal, strongyloids in endemic areas, and TB. Last but not the least, the efficacy of steroids supported by randomized trials, meta-analyses, systematic reviews, mainly the recovery collaborative group, which I was recruiting heavily right throughout, is the overall, it showed a 17% relative reduction in the 28-day mortality, but this reduction was 36% in those on more invasive requirements, so invasive ventilation and ECMO. So the more severe the disease, the greater the reduction in the mortality. And there was no benefit seen in patients who were not on oxygen or ventilatory support, and there was a tendency towards a higher mortality, and therefore steroid is not recommended in this group. Baricitinib, JAK inhibitors, it's normally has been used for treatment of rheumatoid arthritis for its immunomodulatory effects, also found to have potential antiviral effects through interference with viral entry. Until recently, it was on the recovery trial and they stopped recruiting on the 30th of December. So I quite look forward to looking at large scale data on that as well. But it's an option for patients on high flow oxygen or NIV and selected patients on low flow oxygen who are progressing despite steroids. And it can be used as an alternative to tocilizumab if it's not available in ICU patients. And the studies have generally shown benefit within 96 hours of hospitalization or use earlier on in the ICU admission up to 48 hours. It's not used if the patient is on an IL-6 inhibitor because the safety of the co-administration is not known, or if it is used, then you leave a gap between these. Caution in immunocompromised patients can be used with or without remdesivir, and the dose is 4 milligrams daily up to 14 days, and you'd reduce the dose in renal insufficiency and not use it if they've got severe kidney impairment. Efficacy, as I mentioned, there's mortality benefit in severe disease, and greater benefit is in patients on high flow oxygen or non-invasive ventilation, with no significant benefit in patients on low flow or who are not requiring oxygen. Quick word about tocilizumab, the IL-6 pathway inhibitors. It was observed quite earlier on that markedly elevated inflammatory markers, that is CRP, D-dimer, ferritin, and elevated pro-inflammatory cytokine, including IL-6, were associated with critical and fatal COVID disease. And therefore, it brought up the new treatment pathway to be investigated, whether blocking the inflammatory pathway can prevent disease progression. And therefore, studies have been done in tocilizumab and sarilumab, and also the direct IL-6 inhibitor, cetuximab. So the dose for tocilizumab is 8 milligrams per kg IV as a single dose, though the ICMR recommends a lower dose, that is 4 to 6 milligrams per kg. So you'd give that as a 400 milligram dose, single IV in normal saline. And for patients on high flow oxygen or intensive respiratory support. And if they're on low flow oxygen with progressive disease, despite steroids and with high inflammatory markers, more than 75, we have used that as well. It's used as an adjunct to steroids and not combined with baricitinib. Contraindications to this drug would be hypersensitivity, uncontrolled severe infection, that you have to rule out sepsis, obviously other than COVID, neutrophil count less than 1,000, platelet count less than 50,000, high liver enzymes or those at risk of GI perforation, and you use caution in immunocompromised individuals. Overall evidence suggests mortality benefit in the severe and critically ill patients, and these are some of the references for the evidence of benefit in this. Some other trials did not show such a clear benefit or mortality benefit with IL-6 inhibitors, and some possible reasons could be that the trial showing benefit had greater severity of illness and higher mortality rates and higher concomitant steroid use. And some studies not showing clear benefit showed some trend towards a benefit, though not statistically significant, and the power of some studies may not have been enough to identify an effect. Remdesivir, novel nucleotide analog, in vitro activity against SARS-CoV-2, is a repurposed drug. Previously was tried for hepatitis C and RSV infections, but did not work. It was used to treat Ebola during the epidemic then. Standard dose 200 milligrams IV on day 1, followed by 100 milligrams daily for 5 days. Can be used up to 10 days. Prepared in a cyclodextrin vehicle and may accumulate in renal impairment. So therefore, caution in patients with kidney impairment. We have to closely monitor the liver functions before and during treatment. The efficacy in severe COVID-19. So the WHO Solidarity trial did not show any difference in mortality. And Another meta-analysis of 4 trials showed, again, no reduction in mortality or need for invasive ventilation. But some data from the ACTT trial showed a reduced time to recovery and some mortality benefit only in those of low flow oxygen at baseline. And this is therefore reflected in most of the guidelines, which suggest that remdesivir should be used in that subgroup of patients, particularly early on in the stage of infection. In non-severe COVID disease, there was just a modest benefit in clinical status, but there was no reduction in recovery time in mild to moderate disease. These are some of the adverse effects that can be seen with this drug, mainly GI symptoms and liver function impairment. Monoclonal antibodies. So how they work is that they target the spike protein of SARS-CoV-2, and therefore suddenly the concern with Omicron, because there are so many mutations in the spike protein. So the available agents worldwide mainly are casirivimab, imdevimab, that's available as Ronapreve or Regin-Cov in the United States. It's, to my knowledge, the only one available in India presently. There's bamlanivimab and etesivimab, and sotrovimab, that's Xevudy, which is awaiting approval in India. And the last one, regdanvimab, is mainly used in Europe. So in the UK, I have personally used Ronapreve. We give it in a dose of 2.4 grams for patients admitted with acute COVID with negative anti-spike SARS-CoV-2 antibodies. And we also use it in hospital-acquired COVID who are at risk of severe disease in a lower dose at 1.2 grams. Of interest, the Maharashtra COVID Task Force suggestion for symptomatic patients with more than 2 comorbidities or moderate to severe immunosuppression, we should consider monoclonal antibodies only if the Delta variant is suspected. The recovery trial data showed that it reduced 28-day mortality by a fifth, that is 24% versus 30%. So there were 6 fewer deaths for every 100 patients treated, and it also reduced the duration of hospital stay. And there are interventions with no significant benefit, be convalescent plasma, ivermectin, hydroxychloroquine, favipiravir, interferons, azithromycin, and there's quite a long list. So there's no clear evidence. Obviously, some studies have shown benefit and some not. So these are not now part of any standard guidelines worldwide. A quick word on the outpatient management, which is also an important aspect, though I have not yet been so directly involved in managing outpatients, but early treatment is recommended in non-severe disease at risk of progression to severe disease. We have seen the CDC criteria, and there are 4 treatment options mainly at the moment with some evidence. That is Paxlovid, that's a Pfizer oral drug, which is awaiting approval in India. Then monoclonal antibody therapy, but again, the monoclonal antibody that we choose has to be active against the prevalent variants, remdesivir and molnupiravir, and we'll quickly look at each of these in turn. Who should be prioritized for outpatient treatment with these agents? So the patients who are immunocompromised and an adequate immune response is not expected, particularly if they're unvaccinated, partially vaccinated, or those who are vaccinated but are at high risk of severe disease. And these treatments should be started as soon as possible after symptom onset. So looking at Paxlovid, it's nirmatrelvir and ritonavir. It's a combination of oral protease inhibitors. The nirmatrelvir component, it blocks the viral protease required for viral replication, and ritonavir, it slows down the metabolism of the first component so that it lasts longer in the system. The cumulative dose is 400 milligrams twice a day for 5 days, and you would reduce that if there's renal impairment. It should be started within 5 days of symptom onset, and 2 randomized trials in mild to moderate disease showed a reduction in hospitalization and deaths. And very importantly, it is expected to retain activity against the Omicron variant. Monoclonal antibodies, in many countries have used them. I know the states have. It's a first line for symptomatic non-severe disease in outpatients at risk of severe disease. The issues would be limited availability, cost that must be given early in the disease, can be complicated in the outpatient setting, and that mutations would affect the clinical efficacy. Sotrovimab, which we have mentioned, 500 milligrams IV within 5 days. It's important to note this, it's expected to retain activity against the Omicron variant. The others are likely to not have any efficacy against the Omicron because of the mutations. And this also reduces hospitalization and death in unvaccinated high-risk individuals. Remdesivir is an interesting study. It showed that using remdesivir in the group of patients for 3 days as an outpatient in one RCT with 562 unvaccinated outpatients, at least one risk factor, it reduced the rate of hospitalization by 87%. So in unvaccinated outpatients picked up early who are not severe enough to require admission, this is another option. Molnupiravir has been a bit of a controversial drug, but it's a nucleoside analog, inhibits SARS-CoV-2 replication, used for symptomatic outpatients with risk for severe disease who cannot use the preferred agents. The dose is 800 milligrams twice a day for 5 days, within 5 days of symptoms. And the important thing is that it does not require any dose adjustment in liver and kidney dysfunction. The difficult bit with this drug is that it's contraindicated in pregnancy, lactation, and in people under the age of 18 because of the risk of bone and cartilage toxicity. And also the patients, if they're female and of childbearing age, need to avoid a pregnancy for 3 months after using the drug because of the teratogenic potential. So it has not been approved by the ICMR to date due to the risks, and in the Maharashtra COVID Task Force guidelines, there's conditional recommendation for this, particularly in individuals above the age of 60. And in the people less than 60, it has been left to the clinician's discretion. So this is where we are with the molnupiravir. Now, last but not the least, the Omicron variant of concern. Salient features are the high risk of reinfection in vaccinated or previously infected individuals, though as has been touched upon by Dr. Aggarwal, and the data is pretty similar in all the countries that's affected, that is causing less severe disease. The important things from the treatment point of view is that it escapes binding by the commonly used monoclonal antibodies and are therefore not expected to work. The only one which appears to bind Omicron, though with a lower neutralizing activity as compared to other variants, is the sotrovimab. And this is why it is different. So we use the sotrovimab once it becomes available, 500 milligrams IV, within 5 days of symptom onset. And the rest of the treatments are still expected to work. So all that I've highlighted in this presentation earlier is still expected to work because steroids and IL-6 inhibitors, they tend to work more on the inflammatory pathway within the body. Also expected to work are those which are not using the spike protein to work on the virus. So baricitinib, remdesivir, Paxlovid, and molnupiravir are all expected to work against Omicron as well. And finally, to cap it off, I just wanted to draw your attention to the AIMS ICMR COVID-19 National Task Force recommendations, which are fairly sensibly drafted, taking into consideration the evidence we have so far. And that has only been released and revised about 5 days ago. So just to be aware of this. So it divides the categories into 3: mild disease, moderate disease, and severe disease. So the mild disease is home isolation and care with all the usual measures, and to look out for symptoms of worsening, and which you'd have to seek immediate medical attention. They've also touched upon inhaled budesonide at 800 micrograms twice a day if fever and cough are persistent. For patients requiring ward treatment, you would target a safe oxygen saturation level, 92 to 96%. Awake proning is mentioned, which is a very important therapeutic measure to improve oxygenation in the patients. Steroids, if they're using oxygen, and the one recommended here is the methylprednisolone in a lower dose, that is 0.5 to 1 milligram per kg in 2 divided doses. And they warned against using higher doses because of the risk of immunosuppression. Also touched upon is the conventional low molecular weight heparin and with close clinical monitoring. And for the HDU-ICU, it's broadly similar, but advice is to use a slightly higher dose of steroids. And remdesivir and tocilizumab have been covered here as well. So to revise, remdesivir is only to be used if the symptoms are less than 10 days of onset of symptoms and who are having moderate to severe disease requiring oxygen, but not on invasive ventilation or ECMO, and to not use it for more than 5 days. And similarly for tocilizumab, if there's rapidly progressive COVID-19 requiring oxygen supplementation or invasive care, preferably to begin with steroids, and to look for evidence of active TB or active infection. And that brings my presentation to a close. So thank you very much for listening.
Thank you so much, Dr. Shahid. Dr. Niranjan, I would welcome you, and I think you have a very daunting task of getting a quick message across because we are towards the end of our session. Sorry for that, but all the speakers shot their timing a little, but I think it was very engaging, so it's fine. So Dr. Patil, can you please give some comments on myths and facts around Omicron?
So, thank you, ma'am. Thank you. I would like to thank all my speakers because they have made my life simpler. At the same time, I can say a bit difficult also because they have covered everything. So I'll just be touching few things, which maybe, which we maybe have touched, or, which something, which we can emphasize a bit, I can say rather. So with that thing in mind, I'll just start my presentation. I hope my slides are visible. Okay. So in today's today's session, I'm going to cover the following topics. I will be speaking of the structure, the lineage. Although it has been covered, I'll just have a very brief word or two about lineage and the nomenclature, the facts, some cases, vaccination studies. What about S-gene target failure? Some things about genomic surveillance in summary. So this was happening in the last month where we were seeing such newspaper, or I can say where. News where we were saying that the Omicron is spreading across the world at an unprecedented rate, and this continues so right now. Although the South Africa has seen quite now a plateau and decline now. So now this brings us to the present thing where what is this coronavirus, and just to touch upon it, I think it has been covered, but we should know that even previous to this coronavirus, SARS-CoV-2. Which happened to be in the year 2019, December. We already had a few other coronaviruses which are in circulation. To name them were coronavirus 229E, coronavirus NL63, OC43, HKU1. We also had Middle Eastern respiratory syndrome coronavirus, and then we had SARS-CoV-2. Just to look at the structure, that we have a S protein, which is a surface protein, you have a membrane protein, you have a nuclear protein, and you have an envelope protein, and you have obviously the genome. So just to say, what happens in Omicron, as we can see, there's this the spike protein, especially, it has got mutations, and because of these mutations, there is a change in the way the virus behaves. So what happens is it makes because especially the furin cleavage site, it makes the virus that much more transmissible because the virtue of the mutations, it affects how the treatment, especially by the antibodies they act, and also how the diagnostic kits, the PCR kits, how it presents a challenge. So with that thing in mind, just to summarize that, this started this Omicron strain, as everybody has covered, it started in the month of November 2021 at Gauteng province. Similar genomes were repository from Botswana and Hong Kong. Then this led, the researchers, then they gathered all the information. They designated the lineages B.1.529, and then it was then by the technical advisory group. It named it as designated as a variant of concern. And further 2,700 sequences were added onto it. As more and more sequences got added onto it by the GSAID, it led to defining Omicron, which has got many characteristic mutations. So originally it was B.1.529. This was subsequently split by the Pango network in two sister lineages. In fact, three, I would like to say: BA.1, BA.2, BA.1.3. So why this is important is that, while both of these lineages, all the three lineages have the most important spike mutations that were originally defined for the Omicron. The lineage BA.2 does not have a deletion in the spike protein, which is present in the original lineage. How that is going to affect, we will discuss subsequently. Now, so, as we can see, there was a very unusual constellation of the mutations. More than 30 mutations were seen in the spike protein alone. And there was 10 more mutations, in the receptor binding domain. So also in the nucleocapsid region. And what we could see is, when compared to the beta variant, which has got only 3, the delta had 2. So this has been already elaborately been explained by Dr. Vishal. I will just touch this. So this is particularly right now speaking for the world and for the India. So what is our concern is the one which is in the red. Okay, you can see here one which is in the red. This is the phylogenetic tree. This is the spread of the virus and how it is slowly, replacing the delta variant. You can see with this particular thing how it has been replacing in India. You can see here initially it was the alpha variant. Later on it was a delta variant, especially towards the late April and May, carried through the October, and then in November 2021 and the early December, we started having the Omicron strain, especially from the international travelers. So this is how it has spread. So this one can see. So now, what are the infection types? We are talking about infection types, and there are 3 kinds of infection types. We have the COVID-19 knife infection, which is very rare nowadays. Then we have COVID-19 breakthrough infection, which happens in people who are already vaccinated, either by single or double dose. And then this is called as a vaccine failure. And then we have a COVID-19 reinfection. People who were initially infected by a different strain, then they get infected by a strain which is different than the previous strain. So these are the 3 broadly, infection types that we are dealing with currently. So what do we know about Omicron? We know that it is rapidly transmissible. It is super mutant. The R0, what we say is very fast. In fact, it is very close to measles. Immunoescapes is possible. Breakthrough infections are there. It is replacing the Delta variant. When I have to talk about the severity, is less severe in the vaccinated people or people who are having pre-existing immunity because of the prior exposure. How it is different from the previous strains is that 90% of them are asymptomatic, or they might have just mild cold-like or flu-like symptoms. Only 4% may have breathlessness, which will require hospitalization, and out of that, later on, only 1% will have severe disease, and in fact, only 0.5% may lead to death. But the numbers may be overwhelming if we do not take appropriate care, if they overwhelm the healthcare system. So it is very important that they are managed well. Another fact that we have to keep in mind is neutralization of the Omicron is significantly lesser than that of the ancestral Wuhan lineage, 20 to 40 times lower neutralization. And with Delta, it is about 5-fold lower neutralization. This is something which we have to bear in mind. So just we'll discuss one case. This was a 30-year-old international traveler who had tested positive. Even though it was immunized with both the doses of COVID vaccine, the vaccine was utilized was Covishield. Patient had no symptoms but did not want to isolate, even though it was suggested to that patient. Patient kept on arguing, saying that no, she was using a cloth mask all the time. How can she have a positive RT-PCR? And in fact, she questioned the accuracy of the report instead. So 3 days later, her 5-year-old son, her husband, who was staying in the same house, they started experiencing symptoms. He was having fever, which was not relieved in spite of ibugesic syrup. Her husband developed slight headache, fever, 100 degree Fahrenheit, cold-like symptoms, with slight running nose, but it was not profuse. The slight scratchy throat that was seen with irritation on day 3 onwards, was quickly relieved on day 5, but the throat scratchiness persisted. She reluctantly tested her own sample, her husband's sample, as well as her son's samples on the physician's advice, which came positive with CT value as 21 for her, 24 for her kid, and 23 for her husband respectively. So you can see here, it is her report. So what is about that case that I wanted to discuss is that number 1 is doctors, CAs, and lawyers. They are for you, guys. So when they are discussing a case with you, yes, I understand there could be different viewpoint, but please bear in mind that doctors are going to advise you well on this. Another thing is that about the cloth mask, and we will discuss about how cloth masks, how they have led to false sense of security and in fact contributed to the spread of this super transmissible strain. Okay, so then coming to there were certain the diagnostic kits that we have to talk about. So US FDA, it had given certain, I can say, cautions. I just touch upon them, although they have been described, previously. I just touch upon them. So the most important thing that we have to be aware as a laboratory staff and the healthcare providers is that chance of false negative results may occur with any molecular test which have been designed for SARS-CoV-2, especially if the mutation occurs in the part of the virus genome which is tested by that virus, by the test. So that is something which you have to bear in mind, that false negativity is a concern. Okay. We have to understand that the viral genome can result in the change of the viral proteins, and therefore it can also affect the performance of the antigen or the serology test. So it is not restricted only to the RT-PCR, but also to the antigen test and the serology test. Now, so I have described that, there's a high chance with the genetic variants that false negative results can occur. You have to consider the negative results in combination with the clinical observation, the patient history, and the epidemiological information. You have to consider repeat testing in such situations with another, authorized assay or FDA cleared molecular diagnostic test with the different genetic targets if there is still strong suspicion, even in spite of a previous negative result. Test, performance may be impacted by certain variants. Tests with single targets are more susceptible to changes in the performance due to viral mutations. Tests with multiple targets are more likely to continue to perform well. So that is something which we have to bear in mind, that we have to utilize targets, we have to utilize tests which have got multiple targets. Okay, so that even if there is one gene deletion or this another gene deletion, one can always pick up other genes. So that is something that you have to bear in mind. Now, so how does it impact? We have to understand something, that impact of the mutations on test performance is influenced by several factors, which depends on the sequence of the variant, the design of the test, and the prevalence of the variant in the population. That is something which you have to bear in mind. Now, how does it impact the antigen test? Now, we have to remember that FDA has clearly said into the latest advisory, which happened on 28th of December, that is last month, it said that, the antigen test do detect Omicron variant, but they have reduced sensitivity of detection. The antigen tests are generally less sensitive in situations where there is high suspicion and the antigen tests are negative. They should be retested with a follow-up molecular test, such as a multiple gene target PCR test. So that is something which you have to bear in mind. If it is positive, nothing to worry. But if it is positive, then it is confirmatory. But if it's negative, then you need to retest with a follow-up molecular test, preferably with a multiple gene target. Now, there were certain other cautions which the FDA gave, especially with respect to the tests which are going to fail this Omicron detection. So I have listed them. Dr. Vishal has already described in detail. So one of them being by Meridian and another being by applied DNA. So then what about the Indian scenario? So we have to understand that there are at least 2 kits in the Indian scenario which detect single gene and which is impacted by the gene mutations in the Omicron. So that is your Cepheid and the other is your Aquila. So that has been described in detail. So I will not overemphasize. So especially, so there are certain issues that we need to address. So especially with, say, gene expert, because there is a rapidly utilized test, or more commonly utilized test, especially in hospital settings. So we need to understand something, that yes, if it is positive, clear-cut positive, nothing to worry. But if it is presumptive positive, that is something which you have to, take care. Something which is the results which are negative, which we have to, do a repeat testing, preferably by an RT-PCR test, which utilizes the multiple gene targets. So this is something that we have to bear in mind. So this may happen especially with people nowadays who are vaccinated. So the vaccine will impact the viral copies in the patient's specimens. So that is something which you have to bear in mind, especially, So then what about the gene dropouts? We have N gene and H gene dropouts. They're not observed in Delta variant. So that is a very useful information when we are considering the therapy. Specimens with gene dropout detection pattern may be Omicron variants, and they should be prioritized for sequencing confirmation. So now this is what we are doing. We are offering a test which is called as COVID variant screening, where we are utilizing multiple gene targets. We are also utilizing certain mutations to identify that this is likely or probable. We are dealing with a case of S gene target failure, which is probably a case of Omicron. Okay, So here we can see that we are saying very clearly that this is positive. With a CT value of 24, there has been an S gene dropout or an S gene target failure, and the ORF1 target gene and N gene, they both have been detected. So if you look at the interpretation table here, so this is, we are probably dealing the first case scenario here where we are dealing with a COVID variant, probably COVID Omicron cluster BA1. Okay, and for confirmation, whole genome sequencing is to be done. Now, what if there is no S gene dropout? So then either you are dealing with probably are dealing with a case of Delta, or probably are dealing with a case of BA cluster 2 Omicron variant. So that is something that you have to bear in mind. But having said this, the cluster BA2 variant is negligible that we have been observing. It is predominantly BA cluster 1 that we are observing in maximum number of cases. And believe me, we have identified hundreds of such cases, and I don't want to overemphasize the percent positivity of BA cluster 1 Omicron. The RT-PCR, something that that I was talking about, so usual RT-PCRs, they have certain regions, or there are certain segments of the DNA which bind to the genome of the virus to specifically amplify a genomic region, so that we call as them primers. Generally, an RT-PCR kit will have 1 or 2 such target genes to increase the sensitivity and specificity. Now, if there is a mutation in the virus genome, which could be incidentally where the primers bind, this could make the primers inefficient, and this is called as the target failure or the dropout. So how will it impact the diagnostics? So as we are saying, so it will definitely impact the diagnostics, especially if you're utilizing only one gene target, and that too if you're utilizing say S gene or N gene. So then if there is if that particular patient was carrying an isolate which was having this this variation or this mutation, then this will be not picked up, and this will be picked up only if you're targeting multiple, you are having a test assay which is targeting multiple genes, confirmatory genes. Okay, so which could be your N gene, which could be your ORF1, or which could be your S gene. So that is what we are trying to suggest. Okay. It also highlights the importance of genomic surveillance for accurate assessment. Now, how it is going to impact the treatment decisions. Now we have to understand something that, I have discussed this, that when you are using monoclonal antibodies for therapy, so if it is an Omicron variant, you can just avoid using those cocktail therapies, because they were, as my previous speakers already spoken at length, how they are designed against those particular S gene or surface protein targets. So now, if there is a mutation in that region, they are likely to be less useful. So that is something we have to bear in mind. And again, if there is no such S gene target, then we are probably dealing with a Delta case. And also, if it is a cluster BA2, still your monoclonal antibodies are going to work in those situations. Okay, so you're going to save nearly 1.2 lakh rupees per vial for the patient and his family or her family, in this situation. So that is very important for us to identify, what variant that we are dealing with. How it is going to impact international travel. Obviously, when you're going to have such patients, who are coming into a country where there is, the test available for COVID, variant screening, so you can actually isolate and cohort these patients at the airport itself. Okay, so depending the whole genome sequencing results, which can take 5 to 7 days, depending upon what kind of assay that you're using, so till that time they can be cohorted together rather than mixing them with a Delta variant. Okay, so then we want to avoid that situation. Secondly, we can prioritize those kind of samples for whole genome sequencing. Then for infection control purposes, again, you can cohort those who are having say Delta infections and those with Omicron or suggestive of Omicron, S gene target failures. So you can basically cohort those kind of patients, and the infection control practices can be directed accordingly, as we all know. And then it can also, obviously, it has got great impact on the clinical trials, the clinical research, and the newer drug development. This is just a fun thing, and it is not to be taken seriously. What are the senses affected by COVID-19? So I would like to say, common sense is the most commonly affected sense, over and above the taste, the smell, and the hearing. Now, there was data that has been presented by my previous speakers where they are talking about, how this, the sense of taste, the smell, and hearing was affected in the Delta variant, even in the ancestral variant. There is similar thing that has been observed even with the Omicron variant, but to a lesser extent. The taste, especially, it is reduced. I cannot say it is completely absent, but it is reduced, and it is especially reduced for the salt, salty kind of food stuff that you will notice. Okay, you will feel that that you're having a food which is which has got either there is no salt or reduced salt. So that is what you will have this, but you will have this around 5th to 7th day of the illness. Now, what about vaccination? Now, vaccination, we have to understand that presently the vaccines that are available, there are two kinds. One which are infection preventing, and others which are disease modifying. So the most vaccines which are currently available, they are disease modifying. They reduce the disease severity and outcome. That is, they prevent the severe forms of the disease, so that the patient, so the infection may happen, okay, but it may remain asymptomatic or it may remain mild, and it will there will be infection. The duration of the infection will be shortened. Also, the virus shedding will also be shortened if you are well immunized. So this is what I mean to say by the present vaccines are more likely to be disease modifying rather than infection preventing. Please remember that vaccines are not masked. The virus will still get inside your body, it will cause infection, but by virtue of the vaccines, the disease will not be severe. You will have maybe an asymptomatic or only a mild kind of illness. That is something that we have to bear in mind. Again, these vaccines may not prevent against infection by a new strain or reinfection from an existing strain, but again, the severity of the symptoms will be much mild. Now, what are those early studies which we have currently available, which talk about the usefulness of the vaccination against Omicron? So, this study was done by the Discovery Clinical Research in collaboration South African Medical Research Council, where they did analysis between November 15 and 7 December on people who had taken 2 doses of Pfizer-BioNTech. So results were based on 211,000 patients, positive COVID patients, and out of which 78,000 were Omicron. So what was observed? So what was observed was, with respect to Delta, the protection that was provided was 80% against avoiding any kind of infection, whereas against hospitalization it was 93%. But with Omicron, the same protection, it failed by 47%. It became 33%, okay, against infection, whereas against hospitalization it was only 70%. So suggesting that only 2 doses of this Pfizer-BioNTech would be insufficient. The same was also covered in the newspaper articles. So there is a 47% decrease or reduction in the protection against infection and 23% reduction in the protection against hospitalization when you are compared to the unvaccinated individuals with respect to the Delta strain and the Omicron strain. Now, but we have to remember that even though this is that we are talking about on the basis of the antibody study, but still the patients did not suffer from the severe forms of the disease because of the the mutation that were there. They could not escape the T-cell response, that is cellular immune response. This is something that we have to bear in mind, that the cellular immune response will be there and will help us from the severe forms of the illness. Now, what about the Covaxin study? The Covaxin, which is now being, which is being now been given by the government of India to healthcare workers as well as to children between 15 to 18 years of age, and considered to be one of the safer kind of vaccines. So what was done in this particular study? So this study was conducted at Atlanta-based Emory University. So this the study that I'm quoting is from the RxIV, which was using live virus neutralization assay. Now, so what was done is people who had been given 2 doses of the Covaxin, they were given a booster shot. Okay, so serum sample was collected from 13 such participants. So who were taken first 2 doses 28 days apart, and the third shot, that is the booster shot, they received 6 months after. So then the neutralizing response was measured. So it was found that 100% of the test serum sample, they showed neutralization for the Delta variant, and they showed over 90% of the serum sample, they showed neutralization of Omicron, similar to the mRNA-based vaccine, especially the boosted vaccine. Okay, so the booster vaccine with the mRNA. So these findings suggest that the booster dose has got the potential to reduce disease severity and hospitalization with Covaxin, and is up to 90%. So that is something which is encouraging data. I will discuss just one case. There was a family of 4 doctors who tested for the IgG assay from some laboratory, and so they had a history of vaccination done by Covaxin. Both the vaccine doses were taken 4 weeks ago. So then the finding that was there was non-reactive. The doctors, they raised the query to me saying that, can you just look at this? I know that this is not your laboratory, but then can you just look at this? So I said, yes, fine, sure. So when I went through the report, what I realized was it was not a neutralization assay. Okay. So then I advised the doctors to undergo a neutralization assay from the same serum sample, which was utilized for the nucleocapsid protein, and then it came as rejected. So then why this was so, I will discuss in the subsequent slides. So something that we have to bear in mind. So I'll just, so this was that case. I'll just come to this. So we have to bear in mind that, when we're talking about vaccination, then we're talking about antibody levels. We're also talking about a cellular immunity. We have to choose the correct type and the timing for the measurement of the antibody titers or the antibody levels. This is very, very crucial. Okay. So the ideal thing to do is to do a neutralization test. Okay. And the correct timing to do them is at least 15 to 21 days later. Okay. After the infection or after you have taken the vaccine. If you do early, you may miss, there may be false negativity, but then again, remember that these assays are meant for determining the antibody response or your immune response rather than for diagnosis purposes. You have to, again and again, I want to reemphasize this, that antibodies are for serosurveillance and not for diagnosis. Diagnosis only one situation, maybe it was used for this, in the pediatric, the special situation where they were having that MIS syndrome. So only in that situation. Whereas post the vaccination, or post natural infection, then neutralization assay are better to demonstrate the protective levels. Now, so this is one report that I wanted to discuss. So you can see here the spike protein antibodies, now they have come 2300. The neutralizing antibodies are 82%, meaning, so here what we are seeing here is, so this is that we are talking about the numbers. It will just say that if it is more than 30 means it is positive, means that your body has developed some immune response. There are no presently available or validated cutoff by which I can say yes, that this is the protective level to this particular individual. Now, again, this protection is whether it is going to be against for all variants or no, or upcoming variants, we cannot say for sure, but yes, it will do protect us against those upcoming infections, in terms of the disease severity. Okay, so that is what we wanted to discuss. Maybe we can discuss, as and when the questions will come. Because of the lack of time now, I will just rush through this. So this is what, the interpretation of those neutralizing and nucleocapsid antibodies will look like. I will discuss whenever there is an opportunity to discuss this. Now, again, I'll just discuss one case and then we can close this. So now this is a 17-year-old boy who got vaccinated with the newer policy of Government of India that 15 to 18 years can get vaccinated. He develops high-grade fever immediately 2 hours after vaccine administration. The fever was continuous for 2 days, not responding, or rather just briefly responding to the tablet dolo and tablet sponging. But after 2 days, on the 3rd day, the patient develops cough, cold and cough. Now, the mother is blaming that this is possible vaccine side effects. She dials up and checks what is done generally. You just dial up and check up with your friends. She dialed up her friend's son, who was again a 17-year-old guy who was staying in the neighborhood, who had taken the vaccine from the same vaccine booth half an hour earlier. He did not have any fever. There was only mild pain at the site of the injection. Now, mother obviously she's a mother. She becomes anxious. Now, thinking why such difference is there? She immediately posts these things on her WhatsApp group, inquiring that how many of her friends, eligible kids, took the vaccine and who developed such side effects. Now, 9 out of 10 people, they said that they developed mild headache, mild fever, weakness that lasted only for 24 to 48 hours later. This developed 24 to 48 hours later after the vaccine administration, and while few developed pain at the site of the injection. So now what? Now she's perplexed. Now what is the situation? So we'll just discuss this case. So development of fever, within 6 hours of the vaccine administration is unlikely to because of the vaccination. Okay, this is unlikely to be because of the vaccine side effect or adverse effect. Rather, it is probably due to the recent exposure to a likely COVID virus, which is manifesting as an acute infection. So the patient probably had got exposure to this virus before the patient got vaccinated. Maybe considering that probably it was an Omicron variant. So I presume that this was probably 2.5 to 3 days before, because that is the time that it takes to develop the symptoms, right? And obviously the progression to the cold and cough after 3 days of symptoms, this correlates that probably it was on day 5 or day 6 of the virus entry in the incubation. The oxygen levels were 96%. Now, obviously, you will need to rub your fingers because this is a cold season going on. So to ensure that you're rubbing your fingers properly. Chest X-ray was clear. RT-PCR test and reflex test to S-gene variant sequencing or screening was advised. The result came. It said that SARS-CoV-2 virus RNA detected with S-gene dropout seen and presence of mutation was seen. So probably it's of Omicron plus BA1. Antibody cocktail was not required. The patient was treated with paracetamol and vitamin C for the scratchy throat and green-tuss for the antitussive for the cough and steam inhalation. Patient was advised to stay double mask with one mask, at least one of them being N95 at all the times till the time the patient was in isolation. Patient is doing well, no fever for 3 consecutive days, and at 14 days was released out of isolation, but was was requested to continue to wear the mask. So now, just to discuss something important, so in that particular case, that was not an adverse effect, but it was an infection. Adverse effect or side effect or anticipated effect, what is it? So as per the definition, adverse effect is an undesirable or any unintended consequence after administration of a vaccine or a drug. So this we can classify into 2. One which is predictable or also called as type A or augmented, okay, or it could be unpredictable or we also call it as bizarre. So coming back to the predictable ones, which we call as the augmented, meaning that this kind of adverse effects, they are based on the pharmacological properties of the drug or the vaccine. There is generally the extension of the known effect of the, or generally the extension of the known effect. Like for example, having headache or having fever like thing 24 to 48 hours after taking the vaccine, it is an extension, of the known thing. So, so that is a side effect, I can say, or but it is a predictable side effect. It is an augmented response, but it is a qualitatively normal response. It includes side effects, it includes toxic effects, but they're common, they're dose related, they are preventable, and they're treatable. Whereas when I'm talking about the unpredictable type of response, then what are you looking at the adverse effect is? This is based on the peculiarities of that person and not based on the drug's known action. So this includes allergy and idiosyncrasy or anaphylaxis that some people may develop after giving the vaccination, and they're generally very acute in onset. They're less common. They're nothing to do with the dose. They're not dose related. They're more serious. They may be prevented, especially if the genetic basis is known and suitable test to characterize host phenotype is known. So this is something to do with the pharmacogenomics, I would like to say. So here, we can distinguish whether this person is having a side effect or whether the person is having an adverse effect with a type A or type B. Okay. So then what next? So then we are also coming with an Omicron specific test very soon. By 25th of January, we are likely to come up with a test which is specific for Omicron, where we are going to say that this is Omicron, that we are going to deal with. We also have another category of test which is called as a COVID Express test, which is a very rapid kind of test like an Abbott ID, where you give the results within half an hour maximum. So especially suitable for airports or for hospitals where you have to do, in emergency situations. Now, molecular surveillance is an approach where you utilize the whole genome sequencing and the utility of the spike gene dropouts as surrogates to assess the prevalence, to understand the prevalence in the communities, and to assess how it is going to grow, in the community. So it is very important. So now just coming to the one more important aspect of this COVID is that, particularly the Omicron strain, is that when I compare to the Wuhan strain, when I compare to the Delta strain, this infectivity or the transmissibility is close to the measles. Okay, so that is something that we have to bear in mind. So then how do we prevent ourselves? Please remember, get yourself vaccinated, get a booster dose, take the 3 months of vaccination. If you are not vaccinated, wear a good quality mask, preferably which covers, the mask should be preferably an N95. It should be a double mask. Preferably, it should cover the nose and the mouth. The second mask can be a surgical mask, that is a 3-layer mask. In people who cannot wear an N95 mask because of conditions like, say, asthma or chronic obstructive disease, pulmonary disease, in that situations you can use a 3-layer surgical mask with a cloth mask. But using a cloth mask alone is not at all indicated, because it will give a false sense of security. The virus particles can easily go through them, and you can get infected, and you can transmit the disease to others as well. Okay, especially to a near and dear ones who are either diabetic or who are elderly at your home, or kids who are not yet eligible for the vaccines, who are, of those category who are lesser than the 15 years of age. So then, are we nearing? So this brings us to the new question, that are we nearing to an end of the pandemic? Is the journey towards the endemic started? So I can just say that things are hopeful. We already were exposed in the first wave. We have taken both the doses of vaccine. Probably we are also infected with this present, Omicron. So already there have been 4 times of exposure. Now, addition to this, if you're going to take the booster, so obviously you are going to have some good level of immunity for the future vaccinations, of the future variants, against the future variants. But for this to happen, the vaccine inequality has to end. The poorer countries, they also require this vaccination, okay, the booster vaccinations. They also require the primary vaccinations, and this Omicron, yes, it is going to help us. But then please remember that it's better to get vaccinated rather than suffering from the infection, which can lead to complications or long COVID or COVID-associated organ failure or organ damage or other situations. So then, what does this mean for the strategies? So what has been observed in the South Africa is that where the hybrid immunity existed, so in those situations, the outlook is good. Although there was a wave, I would rather say there was a peak rather than a wave. Same thing we are experiencing in Mumbai, or for that matter in India. Presently, there are the rates, the numbers are going up, but because of the virtue of the hybrid immunity and both the vaccinations, and I would like to say the booster vaccination, the things are looking better. Hopefully, the numbers are also, the hospitalization numbers are presently they are less, and that should be our aim, to reduce the number of hospitalization, to utilize the available options that are there with us, whether antibodies, whether the antivirals, whether it is favipiravir, whether it is molnupiravir, whether it is Paxlovid, or whether we are using antibody cocktails. So all that we have to use very judiciously. So I would just like to say that there's a silver lining to this, and hopefully we'll come out of this vaccine. So what is the good and bad of living Omicron? Good is that the severity of the infection as of now in the vaccinated people is less, but it is very infectious. It can cause vaccine escape or immune escape. So that is something that we have to understand, vaccine failure or immune escape. So that is something we have to bear in mind. Good thing is that it causes fewer hospitalization, but presently we have insufficient data, because as in more and more data is going to emerge, then we'll know the actual severity, especially in the people who are having severe comorbidity, more than 2 comorbidities, and in younger populations. Because what has been observed presently in Israel, in the US, is that now younger population is getting infected. Okay, so that is something, I'm talking just about yesterday's news that has been coming up from United States and Israel. So that is something which you have to bear in mind. The kids, who are not been vaccinated, they might be, they might have some severity of this infection. That is something we have to bear in mind. And in fact, the positivity is also more in them. Now, reinfection. Now we have to remember that, at least because there is high chance of reinfection with them. So it is better to mask yourself. So that is what I wanted to say. Thank you. These are my references. I am ready to take any questions if they are there now. Thank you so much.
So yeah, we are towards the end of the session, and though we have overshot our time, but there are 500 doctors online. So to respect that emotion and that excitement and that energy, no matter how long it's taken us. But I think Dr. Niranjan, you can stop sharing your screen, and I would request all the doctors to switch on their video and audio so that we have time for a few quick questions. Yeah. So I think the first question is for you, Dr. Aggarwal, if you could just address that. So there is Dr. Chirag Waghela who has asked, what is the difference in the treatment for Delta and the Omicron?
Okay, so Omicron, because of its very mild symptoms and the disease prevalence, I would not give any specific treatment except for symptomatic treatment. And that's it. The patient will have coryza, that's running nose, stuffy nose, etc. So you just take symptomatic treatment. Such patients will also get prolonged periods and bouts of cough, which will be very debilitating, and they may worry that they have something very serious. Now, this is called post-infectious cough, the treatment of which is just gargles and soothing materials for their throat. So that's for the Omicron. So for the experience that we've had with Omicron, it felt like an anticlimax and a damn squib. We thought it to be something very big, and it turned out to be, a mole. So I reiterate that if everybody, as our speaker, Dr. Vishal Wadhwa and Dr. Niranjan Patil said, if everybody gave us the S gene dropout and all the three test assays, we would be in a better situation. There is so much heterogeneity in our testing that we are bound to question ourselves, are we dealing with Delta or with the Omicron? So I think one important thing that the government should do is make it mandatory to test all genes rather than allowing them to just test for one single thing, which may be a false negative or a misleading test. And then you end up questioning yourself, what am I dealing with? To come back to the question regarding Delta variant, the treatment has to be, the doctor has to be on their toes, the patient has to be extremely vigilant, especially those who've not been vaccinated. And even those who've been vaccinated, they may have an immune escape because of their poor immune response or comorbidities or their biological age. And such patients should have very rapid and meticulous monitoring, pulse oximeter, any drop should prompt them to go to a healthcare worker, and they may actually benefit with the Ronapreve, Casirivimab, Imdevimab monoclonal antibody, especially for the Delta variant and those with high risk. And if you're vaccinated, then also monitoring is required. I personally would recommend testing those patients on day 0 and then day 3 and day 5 empirically, the blood panel with the inflammatory markers. And if they're symptomatic, immediately get admitted if there is any clinical deterioration.
I would just like to add.
Yeah.
I'd just like to add. So sir is has said it correctly. But I would just like to add some things that in the pediatric population, the data that is coming from US, coming from Israel. So because they're unvaccinated, some of them are unvaccinated, not all of them are unvaccinated in US and Israel, the kids. But then what we are observing is that the severity, may be as bad as Delta. But because now why we are not experiencing symptoms in South Africa and India is because we already had that infection. We already had that hybrid immunity. And that is why, the severity is less. I will not say this is a milder form. I will not like to, say that this is damn squib. We are just into this pandemic or this wave. So let us wait because the time only will tell us, especially in people who have who not had infection, who not had vaccine, So that is what WHO also, WHO chief also said the same thing, that please do not label it as a mild variant. We are experiencing mild in South Africa and India because of the hybrid immunity, because of the previous infection and 2 doses of vaccine. Okay, so that is something that we have to bear in mind. Thank you so much.
Yeah, so thank you, Dr. Deepesh, for putting it across so well. So for the benefit of the house, yes, there are 2 different things and it's a promise. At least we at our end, we've taken your feedback very well, and we will make sure or try to make sure that all our reports go out with the S gene dropout and the hint of Omicron. During this webinar also, I got 5 phone calls from 5 different clinicians. Ye kaun sa hai, Delta hai ki Omicron hai. So, that is why we started the reflex, COVID variant screening. And as Dr. Vishal mentioned, while we are waiting for the government approval to start doing sequencing, we have definitely started doing the dual PCR or the reflex PCR to give our clinicians and our patients that comfort and that risk, that you so clearly alluded to. So since Dr. Niranjan mentioned Israel so many times, I have a very tricky one for you, Dr. Peerbhoy. So there is this very senior doctor from Pune, Dr. Arvind Kulkarni, who's a radiologist, has worked in the United States and in Bombay Hospital. He's now practicing in Pune, and he's engaged in research for immunotherapy for cancer patients in Pune. And he has spoken about this, very popular article doing the rounds these days by, Dr. Tel Aviv from the Israel University, from the Tel Aviv University. So would you like to comment a bit on that controversial media article?
Yeah, so just for the sake of the listeners, I will just highlight some of the points that were raised. So it's talking about the draconian lockdown measures, the underestimation of the power of natural immunity, censorship of vaccine side effects, and that demonstrated in countries which had got really extensive vaccination and strong lockdown measures, that still you see peaks and surges of infection from time to time. So whether this is a failure, and what the factors are towards the decline in the wave, and whether mass testing is effective or not. So quite a few things that are covered here. So I'll try to explain from a clinician's point of view, try to be as unbiased as possible. So right from the start of this pandemic, we have seen that there's been quite a lot of difference in opinion between people, as there would be. We respect that, and there has to be a sensible discussion. I'll try to address this. When the pandemic first came on, I think all of us would sort of appreciate how helpless we felt, because for the first time you're seeing young people coming there, dying in front of you, no matter what you did for them, with nothing available on the horizon. And then became pretty clear that there was not going to be one single magic bullet at that time. And you saw in different countries, like sort of dead bodies piling up, hospitals getting completely overwhelmed, several clinicians affected. So whether vaccination was the right strategy to pursue, I would say absolutely yes, as a clinician. For the reason is that because you wouldn't, at that time, you didn't know what would actually work, number one. Number two is that vaccines are they're already established. I mean, nobody questions why you would take your kid for the primary vaccination, etc. And because all these diseases, which we now take for granted that these are, at that time, like, you had smallpox, polio, and all these diseases would have been quite devastating at the time. So it would be not unreasonable to pursue the vaccination strategy. Now, without the initial lockdown effect, it was quite often a panic, this thing, and the governments very often didn't know what to do because it took everybody by surprise. Now, I'm not going to comment on how appropriate those measures were because I never sort of advised them. But in the initial phase, I don't think it was unreasonable because human behavior, what it's like. So everything now, with regards to the vaccine side effects, yes, reported side effects are there, but we have to also balance that against the risk of getting the actual infection. And we have seen the devastation it causes. Yes, vaccines can cause clots and bleeds. We've seen that. We see quite a lot of clots and bleeds in people with the natural infection. We've seen Guillain-Barré syndrome. We've seen so many patients coming back from ICU with critical illness, weakness, etc., long COVID. So absolutely, I think that it has to be balanced with that. Now, side effects from vaccines, we don't know the long-term effects just yet because we all know that it's been, and that's one of the criticism which they will make is that it was all rapidly rushed through. But just like any other drug where you have reporting of side effects, it should follow a very robust policy. Then the other thing that also would come is, as a clinician, have vaccinations been effective or not? Now, from all the data, I have never understood that vaccinations have ever claimed to sort of prevent infection and eradicate the disease. We're not at that stage yet. But as a clinician, what I have seen is there was a clear uncoupling between the people who have received, between the cases and the admission and the number of deaths. And that is actually because who bothers how many common colds there are or flu infection? The cases are, we don't even know that. But if it is becoming a problem where it's overwhelming our hospitals and all the cancer patients, heart patients, kidney patients are all going into the wilderness so I would say absolutely I have seen that there was a time where virtually my ward is completely full of people who were not vaccinated, young or old. So I would say as a clinician, definitely there was an uncoupling. And about the trust side of things as to, whether he said that there was some deliberate sort of hiding of data or anything. So I would say in response to that, that as clinicians, as human beings, at individual and organization level, there has to be absolute probity and integrity, because all the information that I've taken as a clinician has come from sources which we have always been trusting right from the start of our careers in medicine. So, and again, from all the data, like they also say what works and what does not work, because so much of the data is there which says what does not work. So I don't think anybody's sort of trying to peddle any kind of treatment deliberately. And we all know that like giving IL-6 inhibitors, if steroids or whatever, it's got to be a very carefully balanced thing, you see, because we're not expecting that you give this. Like in bacterial pneumonia, you give antibiotics, the expectation is that the patient will completely recover. That's not the case with COVID. You select the group of patients and try to maximize their chances of recovery, because in the end, what will happen. But when you're writing the death certificate for the patient, as often happens, you want to know that you did your absolute best for them. So that's from my perspective. I hope that
no, thank you so much. Thank you so much. And I think
just a caveat here for this question. Sorry to interrupt. To let the fox in the hen pen. There was a statistical analysis which mentioned the risks associated with the spike protein associated vaccines and the protection offered on the basis of age group. So there was a crossover at 45 years of age, which means anybody less than 45 years of age should not get spike protein based vaccines for the risk that it would be detrimental as per the protection it would offer to them. Because anybody less than 45, I'm talking about biological, not chronological, would have a lesser risk of dying from the disease. And they would have more risk of thrombosis. The very important slide that I mentioned about thromboinflammation syndrome. And this is what we are noticing. We are noticing very young patients with coronary events, deep vein thrombosis, chronic massive pulmonary embolism, and sudden deaths that are being there. And unfortunately, I, as a clinician, when I mentioned that it should be put forward as a IFE, that's an adverse effect following an immunization, I said, where is the proof? And it was actually not accepted. Okay. And one more thing, for WITS, vaccine-induced thrombotic thrombocytopenic syndrome, the anti-PF4 antibody, and I've been running pillar to post for somebody to do an anti-PF4 antibody in the city of Mumbai and for the country of India, and not a single person does that. I'm surprised and appalled. And even Metropolis does not do it. The only institution that did it was KEM, and which has not been doing because of the pandemic, and they're getting low workloads. And I request anybody in this forum, if anybody knows who does it, please let me know. I would be the first person to send a whole lot of them for my patients.
We'll take it up. Thank you for the feedback. We'll take it up. So thank you so much, Dr. Peerbhoy and Dr. Aggarwal, for those excellent take on the Israeli note. Dr. Aggarwal, there's another question for you from Dr. Rajeshwari, that there is an elderly patient with mild COVID, and D-dimer is elevated. Is low molecular weight heparin useful, and is there a need to give apixaban?
Okay, so it's a very interesting question. So there is a two-pronged answer. I would give what is politically correct and as per the peer-reviewed journals, which mentions that on discharge, you're not supposed to give them apixaban. It's only for inpatients. But the current experience that I'm having is these patients who get discharged come readmitted with pulmonary embolism or a stroke or an MI after a few weeks to months. That's probably because of thromboinflammation. So as a protocol that we developed in our institute was that those patients who had high D-dimers would get some amount of prophylactic doses of apixaban, that's 2.5 milligram twice daily, for extended periods of time, which included about 2 weeks to up to 2 months. Because one shoe does not fit all. They did a study and mentioned that majority of the population did not have any problems, and some of them had bleeding disorders. But we have to fit the shoe for the specific patient, because for that patient, a pulmonary embolism is 100% or a coronary event is 100% for that specific patient. That patient is not interested in what's going to happen to the rest of the population. So you have to tailor your risks versus the benefits that is achieving for that specific patient. And I would like to share one slide, which is a very important, which may help you to understand, is this slide. So now this slide mentions the risk of thrombosis and coagulation with your spectrum of diseases. And this patient, wherever this falls, would warrant an anticoagulation. And I, as clinician, have seen thousands of such patients, and I've given for hundreds of these patients an anticoagulation, and none of them have come with the bleed, because I have calculated their has bled score. There's a score available online, and they've had a low risk for bleeding. And then I give this to them, and none of them have come with any complications of thrombosis, coronary events, pulmonary embolism, etc. And I have serially monitored the D-dimers at various intervals at 10 to 20 days interval before stopping the apixaban, and they've done well.
That's great. That's an excellent input. So there you go, Dr. Rajeshwari. So I think with that, we come to the end of the session. There are many doctors like Dr. Akhil Contractor and others who have said it was an excellent program. So I thank all the faculty for sparing this time. I know everybody is busy. The war is still on. But yes, with caution, we move forward. And tomorrow is another day. Stay safe, everyone. Goodbye. Good night.
Thank you.